Hi, this is Karen Van Collel, and we are going to go ahead and call the meeting to order. And it is 10:02. That being said, we don't have a quorum of members here yet, although we're almost there.
I think we may
Okay,
have,
are
we
we
got,
there?
we're there.
We are
Over
there
here.
now. Okay, well, let's try again. Hi,
Okay.
it's Karen Van Collel. I'm calling the meeting to order at still 10:02, and we do have a quorum, but Pam, if you could go ahead and do the roll call just to
Okay.
confirm that that's true.
Okay. Alexis Bukowski is not here, but Chris Struck, are you here
I
on
am.
her behalf?
I am.
Ooh, hold on. I cannot hear him. Chris, can you speak again one more time?
Yeah, I'm
Ashley's saying
here.
she can hear him, and she's there, but we can't.
We should be able to.
You guys just
Where's
fine.
can you see if the volume is up on that, please?
Okay. So they can hear each other
But we can't hear them. We should be able to
virtually,
hear
but we
through.
can't. Ah, there we go.
Can you try one more time?
This is Chris Struck. I'm here.
Yay!
Hi, Chris.
Woo!
We can hear you.
Okay, I
Okay.
can now hear you. We should have had you do test. Joyce Case. She did let us know she wouldn't be able to attend. Jared Fowler. Okay. Diane Godfrey.
Present.
Dennis Hollingsworth is not here, but he has Bruce Culpepper, Peggy Wright, and Jill Parker representing him. That's all right. That's all right. Lindy Kennedy.
Present.
Molly McKinstry. And as she is online, I saw her.
Oh.
Sal Nunzo.
He's online, but I can't move him to presenter mode. I don't know why.
Oh,
Okay, thank you, Crystal. I'm
You're
sorry
welcome.
you're having to be on.
You're okay.
Dr. David Shapiro.
I am here at least temporarily.
Okay, and Dr. Karen Van Collel.
I am here, yes.
Okay,
So,
we do have a quorum.
apparently there are two hands raised that are on call-in numbers, so we can't see that on the screen, but can you see it? I have an insider here. No.
Corinne, you can see them, correct? Can you move them over? Crystal?
It's because they're call-in, I can't move them. Call-ins can't be moved.
Okay.
But it's Sal Nuzzo
Okay.
and Molly.
Okay, so Sal and Molly, if you're able to, when we do votes, if you're able to text me, I'm about to give you my phone number and the whole world my phone number. Can you see the,
Can they do it in the chat?
can you put your hand down, hands down? And if you can text in the chat on your phone, raise your hand. Okay, they can't, they're not able to do the chat.
It's interesting if they can raise their hand.
You can raise your hand,
Is
but you
there
can't
a
do the chat.
function? I know that we have WebEx and you do like *6 and then people can unmute themselves. Whatever that was.
I am not aware of that.
What if they email you, Pam, that, you know, who they are associated with the number, and that way we have it for sure for the record, and maybe they, when we are voting, if they could just shoot you a yay or nay.
Okay.
Yeah, would that work since they can't chat?
She was gonna have them text theirs.
Yeah,
You
because
Okay.
it would be harder for me because I'm sharing my screen.
Got it.
So, okay, I think Molly probably has my cell phone number. So Sal, the number is 850-528-8036. That's 850-528-8036.
And I'll shoot Sal an email real quick with that.
Okay, thank you, Crystal.
You're welcome.
Okay, so we do have a quorum, so we can
Yes.
proceed with all of the agenda items. So, okay, so first item up are the meeting minutes, and you all should have received a copy of those from the last meeting. Did anyone have any changes or edits? If not, we will take a motion to accept them as presented.
Motion
Move
to
approval of the
accept.
minutes.
Thank you. All right, so we have a motion and a second. Any discussion? All right, hearing none. All in favor, say aye.
Aye.
Opposed? Okay. Any opposed? All right, thank you.
Before we move any further, I do want to let everybody know that the meeting is being recorded.
Okay. Great, sorry, I was
That's
supposed to
okay.
say that, and
Okay.
we got all caught up with our technical issues, and it is in fact being recorded, it's turned on.
Yes.
Okay, all right, terrific. All right, so the next item is the action items that we had from the previous meeting. If we could pull that slide up, and then we're going to have Pam give us an update on those items.
You can if I could keep up with you guys.
Okay, sorry. It all grooved here. We're still. What is that?
It
Weird.
doesn't.
Doesn't like whatever you just did.
I know, it doesn't like me laughing is what it is. Okay, so the first one is to continue planning an all-day retreat with council members. That's in progress, and I think we're going to talk about that a little bit later on when we talk about meeting dates for next year. Fill vacant council member positions. That is being worked on by leadership. 2 of those vacancies are appointments outside of the agency's control, but we are working with those entities to get those positions filled. Is that you, Corinne, or?
That's
It's
when
me?
people are
Oh.
joining the meeting. It's just notifying us.
That's,
Well, that's a new sound.
yes.
Yeah.
Okay, reword the E+ missing person slide to reflect that end users can edit panels to add new persons for better clarity. That was completed and fixed online. Lunch and learn calendar invite to council members to learn about the new floor transparency website. And that is pending the establishment of those sessions. And Jamie will talk about that a little bit later. The copy of the chart with the slides that show the suggestions that have been implemented or will be implemented in the future for that transparency website that was sent to you guys. If you did not receive it, please let me know and I'll resend it to you.
Was that sent separately?
Yes. Right after, not too long after our last meeting.
Oh, okay. I'll go find it.
Okay. And then, share the HIE legal work group and Hyatt meetings. Those were done. That was done. Request the Department of Health to present, and they will be doing that at this meeting. Reach out to stakeholders for thoughts on HIE transition. That was complete, and I'll be sharing information about that later in the meeting. And then update the prior action items in the meeting, materials to include corrections noted by the council, and that was complete.
Thanks. Any questions for Pam on any of those items? I say we're going to talk about a couple of them today. Right. So now we have the agency updates.
So there are no major agency updates other than our leadership continues to go down and work with the Senate and House on presenting on any legislative bill requests or funding requests. I will share that there's a lot of focus in healthcare for the 2024 legislative session. We're seeing that now. Specifically, we've always had our focus here at the Florida Center on transparency, but we're going to make sure we continue enhancing some of our transparency projects. There's a lot of attention there. As I said later on in another update around the Florida Health Finder website update, I'll share a little bit of further information on what we're doing in the scope of transparency pages and websites. We would encourage folks to keep an eye on any bills that are moving, because we're moving fast and furious. And it's been a very busy, probably like 3 or 4 weeks. But But outside of that, no major leadership changes or anything else to share at the time.
Jamie, are there any bills working their way through that we should look out for related to the work of the advisory council?
There was one that just came out, I think it was filed Monday
Yeah.
from Senator was Rodriguez, I believe.
No, it was Anna Maria Rodriguez, yeah.
That was one that we're prepping for internal bill analysis.
Can you give us the number?
Yes, I think it's,
I was gonna ask about this bill.
Senate Bill 616.
Are there any other bill numbers you would like for us to look at?
We have a bunch that we're looking at, but not all of them touch ACA. Some of them touch Department of Health and other agencies. Let me see if I can compile a list before the meeting ends.
That'd be helpful. Thank you. Lindy, do you have a specific question about that bill?
I do. So, when the department is asked to provide, or the agency is asked to provide input to the legislature, I know you do a bill analysis and it routes through. Can the council receive copies of those?
Once they're finalized.
Yeah.
Let me double check on that if we can. Now that does change because once we do our internal bill analysis.
Oh, I know it changes as it goes.
Yeah,
Correct.
and we sometimes don't have the final product. But let me need to do that.
Thank you. I think they're very, very good learning tools.
Any other questions for Jamie? No? All right, well then, we're zooming right along here. All right.
So, I'm sorry.
Yeah, go ahead.
Jamie, are we going to talk about Florida Health Finder and the update at all
Yeah.
during this meeting?
Yes, we have.
Yeah, it's on 11:45.
Okay, perfect. Thank you. That's all. I wanted to make sure because I was asked the question.
Yep. Okay, so next item is election of officers. That's the chair and the vice chair, and it is an action item. There are 4 nominations that are all the same. It's for me to remain as chair and Dr. Shapiro to remain as vice chair. Is there anyone else who has any other nominations to put forward? I know Diane got left out, so.
I'm making it my 5 nominations now.
Okay.
The same.
Okay, are there any other nominations? I have accepted it previously and so has Dr.
Just
Shapiro.
yes.
So
So there's nobody else.
no arm twisting required on that just yet.
Lindy didn't volunteer?
No, sorry. I think Karen did such a fabulous job.
Right, so really formal here, right? So can we have a motion to accept the slate of officers that's been nominated and presented?
Motion to accept the slate of.
Is there a second?
Second?
Any discussion? All right, hearing none, all in favor say aye.
Aye.
Any opposed? All right, Dr. Shapiro, we're doing this again.
Okay, Molly said aye and Sal Nenzo said aye,
Okay.
just so
Sorry.
we have it for the record.
Right, there you go. All right, well, thank you very much. It really is an honor to chair this group and I'm excited about the year ahead. We'll talk about a retreat that we're probably gonna have in March. We'll get to that later, and I think it'll be a really good opportunity for us to, really be more targeted in what we focus on. Sometimes it's not really clear what, we're doing from meeting to meeting. So it'd be nice to have a game plan and stuff for the next couple of years, best we can, right? Politics aside and everything else that affects what's going on. So thank you very much. Appreciate it. So we have unit updates. Who's going first?
Jamie's
Jamie
doing it.
again. All right. Are you doing all of it?
Yes.
Okay. All right. You're on today.
So for the Office of Data Dissemination and Transparency, we did roll out and go live with the updated Florida Finder website on November, I believe it was the 9th. So you guys have seen in past meetings some of the look and feel we're working on, some of the changes we've made. We did get a lot of this feedback and went back to our vendor and tried to incorporate as many of those changes as we could before the funding under that contract ran out. I'm happy to say we did get additional funds to continue enhancing that website going forward for this fiscal year. That contract amendment terms and value for execution. In the meantime, we have the still updating, we continue to keep working on the website. On November 16th, Deputy Secretary Kim Smoke went down to the House Healthcare Appropriations Subcommittee for a presentation. Specifically, they wanted to learn more about the agency transparency projects. And she presented on the updated Florida Health Finder website that had just gone live the week prior. The revised and updated books for Florida Health Price Finder, My Florida RX, and the landing page, as well as some other agency transparency projects that are outside of the Florida Senate. But all in all, that was a very good presentation. I just think it's listed on the Florida channel if you want to go back and look at that. But we got a lot of good feedback specifically around the marketing, because we did have a paid marketing campaign. And that was the other moving piece that was happening with the Go Live, is we had all this marketing material that was essentially ads, commercials, and that needs to go out. And so we had to coordinate everything to go out around the same time to go live, and that finally did go out, and we're happy that that's out there. You might have seen or heard some of the commercials. They're all over on Meta, Google. You can hear them on audio, and on Spotify, our media.
Sorry.
A lot of
Facebook.
activity with people coming in on this meeting. Jamie, could you talk about that for a second on the marketing? We're saying we hadn't heard any of the marketing. So you said Meta, Google.
So we did Meta, we had Google, YouTube, we had audio spots for podcasts. We did essentially radio ads with Spotify and iHeartMedia. With iHeartMedia, when you get onto their internet radio service, you also pick up all of their radio stations that that are part of their grouping. So there are hundreds of them in Florida that also picked up those radio spots. And then we also had some ads running on Amazon. So I know that might sound like why there. But if you look at somebody's shopping list, diabetic, for example, or somebody who's picking up like diaper routinely and something, you start learning a little bit about kind of what they're in the market for. So that's something new that we did that was insight to me, because it was not something I was doing.
What's the gist of the messaging, the marketing campaign? What?
So a lot of the traffic we're driving to providing transparent information to ultimately help make better informed healthcare decisions. That's essentially what we've done is we did drive a lot of the traffic to the landing page, which is that overall encompassing website that you land on. There you can see all three of our transparency websites. But we also did individual carved out campaigns to each website individually as well. We have videos out of commercials. I think the 1 minute ones, you'll probably see more of those on YouTube. On Facebook, I think we did like 15-second spots. But a lot of it is just transparency and just providing information for folks to make better decisions.
Are you seeing any uptick in
Yes.
utilization as a result?
So,
Okay, great.
So I have some of the-
Yes.
When I do the Florida
Listen for these.
When I do the Florida Finder update later on, I'll.
Okay,
I'll
great.
mention.
Noise. Sorry.
Oh, good.
On the Florida Health Price Finder website, we are close to finalizing the addition of another 99 bundle care services. Currently, that website is 291 common services. We have information on the cost estimates of what those procedures cost, but we're about to have about 390 bundles come next year.
Okay.
So we're happy that we're adding additional bundles out there to that website.
390 more, or it will be a
390
total?
We'll be at 290. We're at 291 now.
Convince them, that's why they're joining.
Oh, so they left and came back. We just thought we were really popular.
Popular on that.
Oh.
For the Office of Data Collection and Quality Assurance, we are nearly complete with our Q2 2023 data certification. We're at 99% currently. And then for the Office of Health Information Exchange, we continue to work on the ITN. You guys, I think many of you here were part of a lot of the learning sessions that went on. I know that a lot of the topics that were discussed here went on to legal work group and Hayek. I think Pam's got updates a little bit later. We have, as far as patient record query, we have over 3,500 Florida healthcare entities connected to the Health Exchange and or Care Quality Framework. These are those national networks. There's approximately 240 Florida hospitals connected to national exchanges. That went up from, I think, 187, was I think our last reported number. 56 are connected to the Commonwealth platform only. It also sharing data for care quality to the e-health exchange participants in the near future. For the account notification statistics, as of the end of October, we have 801 data centers, with 550 of those are tied to a data subscription. There are 245 data recipient agreements, over 39 million lives covered, and over 10 million notifications sent monthly. For the emergency patient lookup system, we continue to educate providers around the state. We have, as of December 1st, 41 counties, 67 organizations with access to E+, 6 credentialed home health agencies. Team is still continuing to work with this provider type specifically to support their required emergency response plans during disasters and evacuations. And Department of Health regional staff have access to E+ in all 7 regions. And for the patient safety culture survey program, the agency continues to work closely to coordinate with the Florida Hospital Association and the Florida Society for Ambulatory Surgical Centers, providers, stakeholders to ensure that everyone is aware about the surveying facilities and make sure they have access to the patient safety culture survey information, material, pool, and education session. The agency is going to close out this year by sending the final notice of the 2023 to the surveying facilities in December. They'll be advised to finalize the decision on who will be the one to administer and begin conducting the survey if they have not already. We have prepared a 2024 guidance and notices for the facilities, and we continue to update our education sessions and our FAQs on our website. I think that concludes our unit updates. Anything else about that?
You didn't leave anything out, but I do know from the Department of Health, those 55, 56 hospitals that were pending getting connected to the eHealth exchange. Those are they're ACA hospitals, and have begun making that transition. And I think they're working with the Department of Health, and Bruce may share a little bit more about that. So they're working on rolling out and sharing through Carrier Quality. So hospitals should be able to share data with them soon, get data from them soon.
Lindy had a question or a comment.
Yeah, thank you, thank you. So Jamie, I have a couple of questions. On the Florida Health Finder, you mentioned before the vendor contract ran out. Has the vendor contract now run out? Have we renewed?
So we have a master agreement that's still ongoing.
Just, okay,
Support. It was the enhancement funding that we had as part of, I think they came to us this past year. That amount was used through our marketing dollars. So if you looked at, I think it was specific appropriation 229, the agency received $3 million, of which was carved out specifically for a paid marketing campaign. We were able to leverage some of that funding to enhance Florida Health Finder as part of that funding. Vendors were able to work together and help us get that done. We did request an additional $750,000, which was awarded to us in this current state fiscal year. That is what's being amended currently.
okay.
So we'll look at what's out there now. We'll call that the phase 1 facelift. That updated the modern look and feel, and now we'll have the phase 2 where we can really get into customizing a little bit more of the usability of the reports that's out there and enhance some of the data.
So 2 questions. So the master vendor, what is the time frame for that contract?
So the Cloud Navigator agreement, I believe right now it's currently due to end, I want to say in 2026.
Oh, okay, go.
And who is that with now?
Cloud Navigator.
Oh, it's just Cloud
Yeah,
Navigator.
that's it.
Gotcha.
The amendment that we're processing now, we have access to that funding just till June 30th of 2024. But we've already started scoping out the implementation plan of what those sprints will be for these next updates. And that'll be amended into that same master agreement since that's already in place.
So that's part of Cloud Navigator's contract. They're not carve outs with different vendors,
Correct.
but there's a different vendor for ENS.
For ENS, yes.
Are there different vendors for the exchange?
So the health information exchange portion is all the same vendor for them, but it's not Cloud Navigator essentially the website development company.
Mhm.
They do some data analytics. We do have other contracts with small vendors. I won't say small vendors, but vendors that do provide us with some aspects of information that gets put on Florida Health Finder. So like the glossary that's out there, we have an agreement with, I think, a company called eBix We specifically contract with them for that information. We're processing an agreement right now with the Society of Thoracic Surgeon to get some information on pediatric cardiac information that's going to go on Florida Health Finder. So we have all these one-off ones, but if you're to ask me who are our main vendors for the transparency websites, it would be Cloud Navigator. They do the Florida Health Finder, they do the My Florida RX and the landing page. And then we have a contract with HCCI. Give me a
Healthcare Cost Institute.
thank you. And they do our price bundle website.
Bundling.
Florida Health Finder. We also have a contract with CoMagin, and they're working on a data tool that we hope to eventually go live and put on Florida Finders.
So the exchange. So we have 240 of our hospitals, but we've got 35,000. 3,500 entities connected, but only 240 are actually connected to a national exchange. Is that what you said?
These are for the national exchange, yes, these are
Okay.
not, and we're not, those aren't our vendor.
Okay,
Those are deferred to the for sharing of continuity of care documents or the patient records,
right,
we defer to the national exchanges.
plural.
Yes.
And obviously some people may not, but the legislation that we just referenced requires a single exchange vendor to be used, I believe.
I don't
that's
think-
single. I think for
It said a trusted national framework.
A,
Yeah, you choose one. You don't have to choose all three.
right,
You can
Okay.
choose one.
you can't.
So she's saying you believe there's options available. You thought with the A means
one.
one, not
A usually means one in statute. So it's just new on the desk. That's why it's top of my mind.
Yeah.
Tomorrow there'll be something else. Okay, thank you.
clarity. Clarity's always nice.
Larry's always good. Okay.
Yeah, we'll make the note of that too, but I'll analysis to make sure that we clarify there too. But I mean, I'm reading just that section. It does say available through a nationally recognized trusted exchange framework.
So Cloud Navigator, HCCI Price Finder, ENS, and CoImagine.
So ENS is currently our point click here.
I mean, Point Click. Yeah. Point Care Click.
Point click care.
Point Click Care.
So much trouble.
Thank you. Thank you.
So Jamie, it looked like you have a lot of notes there, with a lot of detail. Will those all get into the minutes? Because it was hard to
Yes.
write all of them.
Provide these two.
All the data points. Okay,
Yes.
great.
Perfect.
That would be really helpful.
Excellent.
Yeah,
Mm.
thank
Thank
you.
you.
And Jared, we know you're on. We just wanted to let you know that we got the message that you joined us. So thank you. Any other questions for Jamie?
Not till Florida Health Finder.
All right,
presentation.
get ready, get ready. Okay.
I
All
need to-
right, so next agenda item is Department of Health HIE utilization
then-
presentation.
You're gonna share, right, Peggy?
Okay.
Controlling the slide.
She's,
Would you mind introducing yourselves so that they know who you are, so we know who you all are? We have the team from Department of Health.
So I'm Bruce Culpepper. I'm the Health Information Exchange Outreach Coordinator. And I also coordinate activities with other registry program areas within the Department of Health, with the Agency for Healthcare Administration in terms of leveraging some of these HIE services. And we'll talk about some of those in a minute too. I've been working in government before I can even remember. I think it was somewhere in the late 80s, started with the Department of Health in 2014. And mostly I worked on I managed the promoting interoperability program for our county health department, electronic health record system. And all through the 3 stages of meaningful use. And then I transitioned into health information exchange and promoting operability, which is where I'm here, why I'm here today, to talk about that some. And so Peggy, why don't you introduce yourself?
Nice to meet you.
Nice to meet you. I'm Peggy Wright, working with the Florida Department of Health and the Bureau of Clinic Management and Informatics, specifically on our electronic health record. And one of the programs that I was able to get involved with was HIE, the Health Information Exchange. Through all of the facets of that, our direct messaging prompt, and of course, the Health Information Exchange via in context. So the excitement of, HCA coming on board has been is excellent. I've been with the Department of Health for 3 years prior to that, working, bedside nursing. David Shapiro, don't say a word about me, I know too much. But I also worked as director of nursing at Red Hill Surgical Center. Prior to going into nursing, I had a 20-year history in information technology, software development, management for home health, healthcare, hospitals, insurance.
Great, thank you. Jill,
Hi, good morning. I'm Jill Parker. I work with Peggy and Bruce in the Bureau of Clinic Management and Informatics. I'm the Director of Nursing for the clinic side, and I'm an APRN.
nice to meet
And I'm,
you all.
I'm basically here for moral support.
Do you want to share your screen, Peggy?
Bruce is gonna take it first with the slides.
Oh, you want me to, okay, so I need to go back and share.
Yeah, and then
Okay.
So while Pam's bringing up the slides, tell you a little bit about our presentation. So to begin with, I'm going to give a kind of an overview of our Department of Health program areas and how we use the Health Information Exchange services. And then Peggy is going to give you an actual demonstration of 2 of those services that we leverage for the county health departments, which will be, the focus of a lot of what you see as far as our presentation. But we thought that it's important to also mention some of the other program areas within the Department of Health and some of the exciting things we're doing with some of these HID services, particularly the encounter notification service, as well as we've got some things going on too with the patient query service as well. So I think that'll be interesting for all of you. Now, to begin with, I wasn't sure how much time we had on the agenda. I thought maybe 15 minutes or so. And so we're mostly going to do a presentation of the actual system, live demo. And I talked to Pam. She said, well, you have an hour. Okay, well, let's talk about some other things we're doing within the Department of Health. And as I got into that, it was kind of interesting. I said, well, it's good that we're going to share these things. Now, one of the things that I immediately was faced with is health information exchange is a big deal for the Department of Health. I've been doing it for many, many years for many different reasons with lots of community partners. But for the sake of this conversation today, we want to rein in that scope a little and just talk about the 3 services that we're leveraging in partnership with the Agency for Healthcare Administration and give you the background on how we got to where we are. But the first one is the encounter notification service. The second one is going to be the patient query and clinical document exchange service. And then the third was we're going to go a little bit about direct messaging. So those are the 3 major services supported by the Agency for Healthcare Administration for the state of Florida. There are other things going on with the Department of Health. We have modernization and so on and so forth, and we could be here all day talking about those. But these 3, I think we can rein that in and give you a pretty good idea of what we're getting done there. This is
Just one second, I'm gonna interrupt you. Jared Fowler has his hand up, so I don't know if he had a question. Is he unmuted? Jared, did you have a question?
No, no question.
Okay, sorry, Bruce.
And certainly if you have questions along the way, don't mind submitting. We'll stop and answer those questions. First thing is a general definition, and I think most of you understand in terms of what we're trying to do here. We're talking about patient health information and how that information is exchanged in order to serve the patient better, improve patient care quality and support care continuums and transitions of care and so on and so forth. So that'll be the primary focus of what we're talking about today and these services that we've implemented. Now, the other note I wanted to make too is I put together this first package of slides in cooperation with Peggy and sent the draft out for review. First thing I got back feedback wise was too many acronyms. Systems connected to systems connected to systems certified by organizations that belong to another, acronym of acronyms of acronyms. So the first thing I had to do is kind of relieve some of those acronyms from the presentation. And I did add many of those to the end of the presentation. There's a couple pages there with acronyms in it if you choose to go there and want to look at those later. But the ones that were significant and important, I did, include those here. And certainly if you have a question about those, feel free to ask. I'll try to address the ones in general that are significant for what we're doing. And the very first one, I think we all know about, Health Information Exchange. And I think you know about ENS and what that is, and E+, you know what those things are. And now the other one I'm going to tell you about is HMS, Health Management System, which is our certified EHR that the county health departments have been using. And my next slide, I'm going to give you a little bit of background on that one. So if you would move it to the next slide there for me, please.
I would if it will let me. There we go.
Not sure how well all of you see that slide, but this is a chronology of events that have happened over the last really 10 years. And I'm not going to spend a whole lot of time on all of these, but I am going to hit the high points. And the first one I want to mention is the evolution of our certified of our EHR, which is the health management system. We were first certified by the Office of the National Coordinator, which is another one of those certifying organizations at the federal level, primarily responsible for setting standards for health information exchange, currently, but in the past, and I guess to some extent still today, the improvement of electronic health record systems in general and the adoption of those health record systems across the domain of medical systems and that profession. They began with an incentive program based on high-tech funding back in 2009. And that funding for us was routed through the Agency for Healthcare Administration as part of the Promoting Interoperability Program, which previously was known as Meaningful Use. There were 3 stages of that, stage 1, stage 2, step 3. Our system has been certified through all 3 stages. We spent a lot of time from 2012 to 2016 doing that work of meeting all of those federal expectations of what a good EHR should do. And the important thing to know about that is by the time we got to stage 3, interoperability became the focus of meeting those incentive measures. And we were able to do that as well. And that's when we really began to make this journey into using somebody's services for the account notification service, for patient query, and for direct messaging, and begin to integrate those into our operational systems. Now, prior to that, we had many engagements with the ACA and other agencies on patient query. And, and really it was quite the journey. I'll just say that, right? We learned a lot, certainly, but we did finally get there. Okay. In 2016 to 2017, we started making a lot of headway with that. And another real important thing I think that happened is the focus of the funding moved from meaningful use for expansion of our EHR system into promoting interoperability. That drum began to be beat by the federal government, by ACA, by a lot of people. Let's get interoperability going. And so we started putting a lot more effort on that, and some things in the industry and the infrastructure began to happen to make that possible. And we'll get into that in just a minute. But as you move through around 2016, as we got through the meaningful use phase of this, we moved into promoting interoperability. We added direct messaging to our EHR. And frankly, that was for patient portal, which was a requirement for interoperability, for meeting the meaningful use measures. And then we added direct messaging for transitions of care between providers. Truthfully, we didn't really do much with it for a couple of years. It just wasn't mature. The product we were using was from Microsoft HealthVault. They eventually ceased to support it. And so we had to change directions. Even though we had implemented the capability, it just wasn't being utilized. Plus adoption among our patients and all that kind of thing was pretty weak. So for a year or two, we had to look for another vendor. And we've continued to focus on improving our system and meeting other measures, but eventually we did. We found another vendor and we established a patient portal, fully integrated direct messaging into that solution. So our patients are able to communicate with our providers, and that's a bi-directional communication. And that's been a feature of that system for a long time now. And then the other thing is transitions of care have begun to take, for provider to provider communications. We're able to do that. And we do get, for some county health departments, they leverage that to some extent. And that is kind of an addition to what we do for patient query. When we go ahead and look for records on the national networks, because normally with a transition of care that's done through direct, you can include other types of medical information as attachments. It's a richer, capability there. So sometimes when the appointment's going to happen and treatments requires it, then we can use direct messaging as a secondary way of getting other information, additional information. So, but it's there, it's operational.
Can I ask a quick
Sure.
question? Long time ago, because I've been doing this for decades, but when we were long time ago, when we tried to do patient lookup, even not just ENS, one of the things was the county health departments were all on different systems. And are you all on the same electronic medical record system now, so you can see each other's information, all of the county health departments?
We have the same EHR, which is HMS, but we have, right now we have 67 different instances of HMS. We're in the process of consolidating that into one database.
So And then somebody in Orange County can't necessarily see what's happening if they're seeing somebody in Tallahassee.
Until recently, and now that we have the in context patient query functionality, if I'm in Orange County and I have a shared patient with Osceola County, I can search the HIE for that patient and see the other county health department's record
Within your own EHR.
within our own EHR system.
Okay,
Yes,
well, that's an advancement.
it's, yes, we made progress.
That's what I was going to ask, because I just, the last
Yeah.
time was like, well, the county health departments can never even connect to the.
That's the problem.
there's
Yeah.
so many different
Yeah, we're
systems. Okay.
making progress.
Now,
I just want to make sure I understood where we
Yes.
were at.
and even make it even better, the county notification service sends alerts to 20 county health departments, so you know when a patient has been seen. Then that will, basically prompt you to go look them up in the patient
Yeah.
care system. and look at the
Everybody
record.
loves the ENS service.
Yeah, oh,
And
that's
we
great.
use it, a lot.
Yeah.
We'll see that in just a minute. So anyway, as we moved into 2019 and 2020, we began to engage with ACA on some of our interoperability initiatives with some of the other program areas, like syndromic surveillance. And this is when, if you remember, COVID began to really shape everything, and syndromic surveillance became front and center. So we started getting data from the account notification service for that along about that time. And I'm going to talk a little more about these individual services in a minute, but I'm just going to hit the highlights through this timeline. And so we brought on board some of our surveillance systems and began to get ENS data that mostly was for inpatient. That was a gap that we had in some of our current reporting systems for that. To be able to track portable diseases that are high priority. And then we onboarded the electronic case reporting system, and actually ACA funding from the ITEC Act is the reason we even have a e-case reporting system today. That system, we'd asked for funding for that for years. And finally, we got enough to seed it out of the ITEC funding. And sure enough, we developed that system, and then the CDC picked it up during COVID and let us mature that system. And what that's all about is it allows us to have a national solution for collecting case reports on high priority conditions. That's operational, and we'll give you a little bit of information about that in just a minute. And then we onboarded our county health departments to ENS. So we began providing ADT messages to ENS for other subscribers, which we're the only ambulatory practice I'm aware of that participates in ENS. Most of it's hospital systems, right?
As data source, correct.
That's right. And then we also began receiving ENS encounter alerts along about that time. One thing, and I'll probably just say that for later, how we use those ADT messages, for our master patient index. But anyway, moving on, the next thing up was the patient query on the national networks. So then we proceeded to work with eHealth Exchange via our contracted vendor, which in this case was Audacious Inquiry and CRISP. And I'll describe those terms in a minute, who they are, the acronyms, who CRISP is. And that became our health information exchange partners. And that coincided with ACA's change in strategy on HIE patient query. Moved to more of a national network federated query solution instead of building, a statewide database for that. And once they did that, and we kind of went that way, onboarded with CRISP and Audacious, and I'll talk about some of that progress in a minute. So we did that. And then along about the same time, we reached out to, I guess, our high-tech funding was ending, and we were like desperate for what are we going to do for sustainment funding? And we hadn't quite educated our budget office yet on our needs there, because quite frankly, we've been spoiled for 10 years with high-tech funding that subsidized some of that. So we were able, though, to work with ACA and work with CMS to secure funding for sustainment of our HIE solutions, right? But that required us to go through a very rigorous certification process with CMS. And I mean, to the point, they interrogated all of our vendors about securing their system. This is where another thing comes in called high trust certification. That was one thing. And they actually, worked with our vendor to hold them accountable for what that meant to be high trust certified. All the things they have to do on an annual basis going forward and so on and so forth. So the whole point there was we got that certification for not only e-case reporting, which was first, we also got it for the encounter notification service implementation of HMS and the encounter notification, the patient query implementation that we did through Audacious. So we're certified for those things going forward as of 2022. I believe it was October of 2022. So that's how we're going to help pay for some things going forward. That doesn't cover all the costs, but it covers a portion.
You said Audacious, isn't that the one that was acquired by Point?
Yeah.
So that's how you're connecting to the National Health Exchange is through that
Yes,
pathway.
that's right.
Okay.
Actually, point click here, quite audacious, here, I guess a couple of years ago.
No, yeah, well, a year ago,
It's
in
like
twenty
took me a
twenty-two.
while to
2022,
make that
yeah.
switch. Yes, and we've had a good relationship with them on a lot of things. So, so far, that's been a pretty smooth transition. I mean, it causes extra work because you're transitioning between vendors, but the people we work with have been very helpful. So anyway, that kind of brings us to today, and we've onboarded a couple of our registry programs recently, brain and spinal cord injury program to the ENS service. And that was kind of interesting. They're onboarded as a a data subscriber, right? They're not a data contributor, but a data subscriber. They have a client panel that they submit for matching, right? So they can confirm when any of their existing clients are being seen at a hospital and make sure that they're getting the proper services that they need. There's some follow-up. Then we also have something called Smart Alerts, which looks at discharge information and trying to determine when some of these clients might need these services. And then they're able to see if those people are being referred back through providers to the program area and fill those gaps in service where they might not be happening, right? Now, I will say they're in the process, they're getting the data and they're working on their analytics, and that's coming along really well. But that's, we're excited about that one because it's going to, I think, be a precedent setting solution for other registries that we're looking at. And I've briefly mentioned those. So that kind of brings us to the next slide. Any questions about the timelines and where we're at here? So you can see it's been a journey. And but we're really beginning to benefit from a lot of that investment in the infrastructure and getting these services out there. All right, so the first thing I want to do is talk a little bit about the encounter notification service utilization and the county health department continuity of care service, which is basically using our EHR to receive those ADT messages and to generate the ADT messages that are being utilized by the service by subscribers. We have an ONC certification for that system. Let's see, let me just see which bullets up there might be significant. Well, so to give you a little bit of an idea of volume, over 2 million discharge alerts have been generated by CHDs to date. So in the last couple of years, over 2 million, right? That's ADT messages that we've sent. And we're currently getting about 750,000 every quarter. That's what we're receiving on our patients that are being seen by community partners, right? That's a lot. I mean, that's a lot of ADT messages. And we have about 460 of those participants that are data suppliers that are actually contributing ADT messages to us. So that also, I don't know if there's more than 500 or 600 total in ENS that are data suppliers, right?
There's about there's 800.
800. Well,
Over
half of
800.
those, our patients are being seen at over half of those. So we're getting, we're getting some broad coverage out of that. One of our challenges here, and I'm not going to steal Peggy's thunder on that one, but we do get 750,000 messages. That's a lot of work to sort through those, and they're not all significant for our care, right? And she can speak to that more. All right, next slide, please. These are some of the other DOH program areas that leverage the ENS service. Syndromic surveillance, which I mentioned earlier, they're getting an inpatient feed in real time every day. Anytime patients are admitted or discharged from the hospital, they use that for disease detection, analytics. They look at that information. They're looking for outbreaks. They're looking for any other high priority conditions. They do their basic analytics on it. They've been doing it for a long time, and this was a gap for them to get that information. And it also provides them a means of quality assurance against some of the other data feeds that they've gotten historically. So there's some overlap, some redundancy there, and we're looking at that in the future for part of our monetization. But there is a real value in having that cross check on the data. And there's other things that they get because it's real time. Emergency medical oversight program. This is local EMT transports. All of those from all around the counties in Florida are being delivered as ADT messages to the service, right? So some of those are pre-transport, and some of those patients don't even make it to the hospital. So it's good to have that information. Right?
So I see the treat and release and said, oh, okay, well, they're not even going to the hospital,
Right.
but are they also sending ENS for those that they do transport to the
Yeah.
hospital?
Yeah, they do. I think they might
Send, but I think they're filtered out at the AI. I think it's just treat and release that we share.
I think so. But I know that they do patient matching on those to try to get feedback to the program area.
Well, that was why I was asking, because I felt like wow, that might be why there's so many that you're getting, because if they're sending those, plus then they get to the hospital and we're sending
you're
an
sending, right.
ENS, and then they're
Right.
admitted and you're getting another
there-
ENS.
I'm-
There's a lot of duplicative
Yeah, there's
communication.
potential, and absolutely, that is a challenge for all of these HIE connections, is redundancy and overlap, and some of these agencies are connected more than one place, some of these institutions. But we'll talk a little bit about that. But anyway, I'm pretty sure that there's some, attempt made to deduplicate that information, right?
Right, Smart is confirmed it is treated.
Okay.
Yeah.
Release.
It's treatment release.
So that is those, and we see those transactions show up sometimes for our county health departments. The other thing is that program area gets that information back from the patients that are seen at the hospital or the emergency room and attempt to match that information up in their system for quality assurance, for post-care follow-ups and things like that to improve their services. That information is provided back to the county health departments. One of our challenges there is our matching rates aren't where we want them to be, but we've got some things in mind that we're going to try to do, working with our point-click-clear vendor to improve that. And there have been some interaction between those two groups to get that done. But that's been in operation now for a couple of years. Disease control registries, I talked about Brandon's spinal cord injury, the stroke registry. We've met with them. We've shared with them what the service does. They've done, the vendors actually run some demonstration queries using ICD-10 code criteria from stroke registry. And this is an idea for preventative type measures. Find out what's going on out there with some of these admissions to see what we can do to get in front of some of these conditions, to reach out to these people. You know, they're having potential stroke symptoms and so on and so forth. So the program area has some vision how they want to go with that. The cardiac arrest registry, we met with them to talk about the feasibility of doing this for them as well. The cancer registry, we've not yet had that meeting, but that is on our agenda. Meet with them to see what the opportunity is. There's a new registry, the multi-drug resistant organisms registry, and they're interested. We've had a couple meetings with them, then the STDs and other state registries. You know, we have a list of those that we're have on our list. So lots of opportunity for that ENS data to provide valuable insight into things that are happening in all these hospitals that can drive preventative, you know, proactive type interventions and education and training for some of these hospitals. E+ preparedness. I think most of you know what E+ is, and I think Jamie reported on E+ and the progress we've made in county health departments. So we use it for two purposes. One, we use some of the encounter notification data for shelter management, missing persons. You know, there are various things that we use for tracking when patients during declared emergency are in one shelter versus another, finding out where they are. So that's one purpose that we use it for. And the team has been great about their training and what they've done with that. And they've been just wonderful to work with. Next slide, please. The other is the patient query and clinical document exchange service. So now we're moving away from the ENS and we're moving to the national networks and how we get patient data via patient query. So the first thing is the CHD patient clinical repository is available to patients. And so we have all of our CHD patients that sign a notification, I guess, what is this?
Initiation of service.
Initiation of services form. So they consent for us to share. And we put the CCDs, which is the visit summaries, into a repository that's managed by our vendor, Chris. And those are made available to the national network. That's inbound queries. So they can see our CCD visit summaries along with lab results and so on and so forth. The important thing about that is that environment is hosted in a different infrastructure, a high trust certified infrastructure, right? But it's not in our EHR system. So if there were, God forbid, vulnerabilities, right, or attacks, it doesn't come into our EHR. It's basically part of that environment. And again, that's been through a vigorous certification review. It's high trust certified. It's part of the national network solution. So we feel pretty confident that's being taken care of, but it doesn't cause vulnerability into our EHR. And so we did that for a reason. That's one of the reasons. It doesn't affect performance in our EHR. It affects performance on that repository that they've got. Now that's when we serve records out. And now serving records, when we initiate queries, we have an embedded application called In Context developed by Chris. And we use that application for outbound queries to the national networks, which they manage on our behalf. And they return those results within that tool. And then those tools are those results are looked at by our clinicians and they make various triage decisions based on what that is. Let's see. We also have, as I said earlier, that's TMS certified as well. So there's been a lot of attention given to how that's been built. epidemiology use case investigations. Epidemiology case investigations. So this is another patient query clinical data exchange service. We're taking the in-context solution and now moving it into a different, it's not really an electronic health record system. It is a surveillance system called Merlin. And that is the Department of Health's repository for cases, that have been discovered and for follow-up. And that we're going to give them the capability too, to look at patient records. So they'll get an electronic case notification that says, we've found an outbreak, potential outbreak, or potential case that needs further evaluation by public health. Then they're able to go use the query system to look up where that person has records and interrogate those organizations about, of those encounters when they occurred and so on and so forth. We haven't looked at ENS implementation there yet, but that might be something that would be useful too for them. Then emergency preparedness patient treatment. So during a declared emergency, E+ is available for us to do patient queries. Essentially, it does exactly what in context does for us in the county health departments, but it's broader in terms of how it's deployed and who can use it. And it's something I haven't mentioned here, but I will in a second about our privacy stuff that we do. Next slide, please. All right, so this is the electronic case management system, which I've kind of already mentioned. You know what it is. It's a national system that allows our public health officer to go in and set up conditions that we're interested in tracking that usually coalesce with national, standards for reportable conditions that are of interest, like COVID and various strains of that and so on and so forth. And then those are connected, the EHR systems can connect to that repository and download that information, and then they use that to apply against their clinical data to recognize, identify these particular cases, which then creates an HL7 formatted response case report, which then gets sent back to the Department of Health for follow-up, right? You get some idea of the numbers over there. You can see we had, this was just a quarterly report. There were 75,000 cases from ECR. We also got cases with ECR, it says first, so 58,000. So what it's compared to is our traditional way of getting notifications was through ELR, electronic lab reporting. That's also a feed that comes into the department. We get lab results and they look at that for these kind of outbreaks as well. But case reporting has about 20,000 cases there have been reported that worked and did not show up in the ELR data, right? So that's quite a gap there. It improves that the system is valuable in terms of what it's looking for and how it's being used. And sometimes it's not all about lab results. And then finally, we've got about 8 hours. So far between ELR and electronic case reporting is about an 8-hour difference on average of earlier notification by ECR than ELR, right? Which can be significant if it's with a serious outbreak of some kind of a serious disease. And I'm sure with COVID would have certainly applied to that, earlier the better kind of a thing. And then finally, you see that there's 9,000 cases, I think, there that where ELR was notified, and ECR was notified that ELR didn't know anything about that particular situation. So they're finding a lot of value with that, and they're continuing to onboard. As you can see, they have 745 facilities onboarded now, 41% of coverage of hospitals in Florida. So good things going on with that one as well. Next. Direct messaging, I think I've already talked about that earlier. We use it for patient portal communications, and we also use it for provider to provider transitions of care. This is a model. Now I'm going to begin to transition a little bit more into our patient query system that in HMS. I'm just a little high level model of how HMS is put together. Patient identification being an MPI that's part of the Florida MPI that's built from our ADP messages dynamically. And that's what we provide patient demographics in the context to match against that MPI, which is then matched against other connecting facilities and organizations. And that's how we get our results back. And then, as I mentioned, our clinical data is stored on site and managed by risk privacy monitor. And I haven't mentioned before, but we have a very robust privacy monitoring solution that's embedded in our county health departments. And we have our privacy officers that all have permissions to work in that application, but it monitors every query that's issued by a clinician within the county health department for appropriate use. It has all kinds of algorithms. It uses AI like capabilities to look for any kind of misuse. And so we've trained all of our staff across the counties, which was no easy feat, to introduce a completely new responsibility like that. But anyway, privacy monitoring is very much a part of what we do. And then the national networks, we have 3 national networks: eHealth Exchange, Care Quality, and Commonwealth. Mostly we use these for connections locally within communities in Florida. We do that through our relationship with our vendor, who then we work with these implementers like Epic or hospital systems or health systems that are implementing their connectivity on behalf of one-to-many facilities. So sometimes we'll get a connection to a direct connection to a facility. Sometimes we get a connection to a service like HCA. It then connects to all of their facilities and then returns results back to us. So it's quite a mixed bag there of how things are actually resolved, at that level. So with that, let's move to the next slide, please.
Sorry.
Utilization. So this is what we have so far. You can see among our county health departments, it's progressing on an upward trend, especially since we began to onboard more and more connections that are right over there. You see a few peaks and valleys. That's sometimes like the last one, a little bit of a downturn. That's November. That's because of all the holidays, that we had and the clinics were closed. So, but generally the trend has been up. And as we add more and more connections for our clinicians to find value with, we expect that to really continue to rise, especially now that we've got the HCA on board. That's going to help a lot too. Next. This is just a screenshot. You can see these are document returns in some of the facilities. This is out of our dashboard, our monitoring tool for all of our patient queries. This is a 1 week slice. And these are actual document retrievals that are happening. This is the care quality. And so you can see that these are, if you looked at patient discovery requests and you look at what I'd call document list requests, they're just 100 times more than this. But this is where we actually found records we were interested in and pull those back into the county health department to be used during an encounter with a patient or a visit with a patient. And you can see how the numbers are beginning to go up. It fluctuates a good bit depending on what's happening, is it a weekend or whatever, but it's growing, and that's care quality. And that's new for us. We've only had care quality operational for a few months now. And so we've really begun to accelerate our onboarding for those systems. And you can see these aren't individual facilities. These are healthcare systems like HCA Healthcare represents hundreds of Florida facilities. And the Commonwealth is an umbrella connection. And then we have others like with a lot of the Epic ones that are more one-to-one. Now go to the next slide, please.
Yay. But.
That was how early on.
You were, I know, but I wasn't seeing us up there. I'm like, oh, let's get to you.
Yeah.
This is the first connection that we implemented, and this is where our connection originates. We are connected through eHealth Exchange to Care Quality, to Commonwealth, and that's what you've seen with those results earlier in the previous slide. But you'll see that our volume in Health Exchange has always been a lot more than Care Quality, but that gap is narrow. That gap is narrowing. So yeah.
I have a question. Is there a distinction between the bold numbers and the unbolded numbers? Is that just?
I think
That's total.
Is it totals? Okay.
That's subtotals for the.
Okay, I see.
I see it now.
Thank you.
Ability to click on some of these.
Thank
things
you,
and drill
Diane.
down, look at facilities that are involved with some of these. And we have other metrics. We can tell which county health departments are being served by which institutions and so on and so forth. There's more drill down, but this is just a sample. You can see what our dashboard capabilities, a small sample, how we can go back in time and spin forward and aggregate and shape our data to help make decisions with our vendor about what to do next. And Jill is a very, she is the person who works in the county health department along with Peggy to find out what their priorities are for connections. And then we basically have to go hunting for OIDs, endpoints. An OID is another acronym that you learn in this world is real important. That is the endpoint for a particular facility or an entry point into multiple facilities. And that's our golden ticket, so to speak. Next slide, please. Health exchange benefits. Well, just a little bit about our population. It makes HIE really important to us. County health departments patients tend to be more transient. They move from, from environment to environment, all parts of the state to state. And there's a lot of, we're very transient. So it's good that we can share records with other entities for that purpose. That's a major reason for wanting to do that. They seek care from a variety of different settings. So you have a lot of records that exist in different places. They have more complex physical and mental health issues. And then they're less likely to have a primary care provider, right? So that's another reason it's important, not only for us, but for anybody who might see them to be able to see our records. You can see the list. We have, to further define that, and Peggy will talk a little bit about some of those things that she's finding too. I won't spend a lot of time on that one. Next slide, please. All right, so Peggy's up,
Okay.
unless there are questions. Any questions?
Just two comments. One on the transient, because you're connected to the National Health Exchange. Do you have a practice? Is it part of the workflow to go ahead and say, hey, I'm from New York, and they check out and see if there's any information on them nationally? Or is it just dependent on the practitioner that's seeing?
I think it's
Yeah,
dependent on the
I figured.
practitioner.
And then the other thing I was wondering, you talked about future uses for the ENS data from EMS and from others. I don't even know if you could get it, but are y'all looking at from an opioid overdose situation and the use of Narcan?
Mhm.
And who's giving Narcan, because I know EMS has to report it now, hospitals have to, they don't come in through EMS. So I was just
That's a
wondering.
good point. I don't think we specifically have addressed that. We've addressed the need to be able to do those kinds of things. And, we're connected to the PDMP and all of that through our e-prescribe solution. They're connected to PDMP and we benefit from that. But this kind of analytical, that's certainly some of our registries would be interested in that kind of thing.
I just don't, that's
I
a,
had thought about
it's
that.
also, you have to
That could
look
go on our
at
agenda.
the laws that
Mhm.
cover, that oversee that, but that's something to.
That's a good
consider.
point. We want to have the flexibility in our framework to be able to respond to those kind of things without having to go request gazillions of dollars from the legislature and waiting 2 years to implement. So if our infrastructure is in place, right, with ENS, and we're able to onboard easily, then we're able to respond to those kind of things in an efficient way.
I'm sorry.
Well, no, I have a question. I apologize for having to step out. So the DOH data is for DOH patients, clients, for lack of a better word.
Yes.
Okay, okay. And, is there Cs listed, although I was out for a bit? Are you sharing with FQHCs?
Yes.
Is that where I would think,
Suncoast.
okay,
Yeah, we're starting to onboard them. We are connected to Suncoast in the Hillsborough County area. We're getting ready to connect to Ibarra Health, which is Pinellas County Community Health Centers. And then we have a few other that we have connected to, but we're actively reaching out to them to make sure if they are available through Care Quality, Commonwealth, or eHealth Exchange that we're connecting. The problem is we have to be able to test the connection, we have to have a shared patient with the other facility, and it's just
Not always.
it's not always
Up with it, right?
easy, yeah,
right.
to test it.
So, and I haven't done much in the Department of Health, public health space, but there was a time when primary care was being totally moved out.
Mhm.
Is it still out?
There's still a few counties that provide primary care.
Okay, so you're doing prevention, disease control management,
Primarily a
Testing,
public health
screening.
focus, but we do have Walton, Bradford, and Union are still FQHCs as well. And then we have a few other counties. Pinellas County provides primary care. So it just depends on the needs of the community.
So, and this may be getting off on a tangent, but obviously medical home is the big desire these days. And we heard the Senate this morning really wanting to push medical home. When you have a patient, a client in your system for something in the infectious disease category or other, what are then the steps to connect them to a medical home?
It varies from county to county.
Okay, so it's really localized.
Yes.
Okay. Do you have a county, a model, a CHD that does it really well? That could be, used as a model?
Probably Pinellas County would be a good one to look at. I believe they also, they have a big primary care clinic for the unhoused population or the homeless
Mhm.
population. And so they do a lot of referrals to that local collaboration that they have. But Pinellas County would be a good one that's, that would be a good model for primary care. Other than Walton or Bradford Union, and they're FQHC, so they do have the continuity of care there.
So after a client is tested and then added in the infectious disease, registry is not the right word, but, then what happens if we're not connected through technology? Then how do we ensure that patient is getting their treatment, doing the things you're suggesting that they do?
It depends probably, on the program, like the TV program, and they have, there's.
PB's, yeah, the
Different.
PB's different.
Yeah, it's different. STD, we do have DIS staff that go out into the community and treat patients. Like they'll track people down and treat them. So it just depends on what the program focus is.
Well,
Yeah.
thank you for spending a few minutes bringing me up to speed.
Oh, you're welcome. Yeah.
Before we go to Peggy, does anyone who's online have any questions for Bruce? Just to make sure, because it's,
We did have one comment from Brian Smart that said, Point Click Care is working on a state dashboard that would provide the agency with a report on opioid emergency department encounters and provide that data at the county level.
okay, thank you.
Sal said no questions.
I did want to add on to your initial question about how the local workflow is. We do have a few counties, the larger counties like Pinellas or I'm forgetting the other one, that they actually have the IT staff download the ENS messages every day.
Yeah.
And then they have their own process where they make sure the information gets to the right program office to make sure that the patients are followed up on and they have continuity of care. So there's some counties that are a little bit more advanced at using the data than others.
Yeah, that's important. I mean, if
Yeah.
the data's not being utilized and it's not meaningful
Mhm.
to produce a better outcome, it's just data
Right.
going to the vital statistics office.
Right.
But the key is they already have access to it and
They
it's
should be,
available. That's the
exactly.
key. They have access to it and they have access to the e-health exchange to share data. So that's to me the key. And that's available today.
All right, sounds like pass off to Peggy. now.
Sounds like it is time. All right, so I'll be demonstrating and illustrating how we've matured and how it's very easy to get this information and how it's really difficult to get that information. Sometimes you're, hunting for a needle in a stack of needles.
Okay.
Take a look at that.
Different.
Sounds painful.
Forget the H-stack. So we talk about, prompt, and we've said this before. I like to use it as to saying, I'm looking at ENS, I'm looking at the encounter notification, and it's prompting me to dig a little further. It's allowing our clinicians and our CHDs to make the determination. So here is my list of patients that I had. I'll show you how this looks. And I can look and dig into the encounter a little bit, but I can't see anything more. Well, if I'm looking at my patient and I see that they're in for a broken ankle, it's not that I don't care. Of course, I'm completely empathetic to them.
So I have a message that says that they're not seeing what you're presenting. So
Did
one of
you-
my team members is on virtually.
You
Says we are.
You
not
see it on
seeing her
yours?
machine.
Was it in the packet that went out?
No, well, I mean, it should be showing if she's seen it on Teams and I'm seeing it in here.
On the screen.
Anybody else see
Hey,
it?
Ashley, can you see it yet? She's asking our others. She's like, yeah. To see.
So are they just seeing the camera?
Are you just seeing the camera? Now, yes. Now you see the camera, but not the slide.
You can stop sharing again.
Yeah. See if that
Correct.
helps.
Okay, so not the slide. Just
Okay. Yeah, try sharing again.
gonna reshare now. Okay. Can you see it now?
Does anybody say anything in the chat? Can you ask them if they're seeing it in
Good.
the chat?
It's good.
Okay, we're good.
Good.
Are you seeing it on your end? Okay.
Yeah, they can see it now.
Okay.
Thank you. Sorry to interrupt, just figured.
Okay.
Get that up there.
It's no good if I,
Right.
can't
Okay.
do charades to them.
You sure?
Probably
Things
could,
more
but,
interesting.
So again, I can see that, one of my patients has gone into the emergency room and has a broken ankle. And again, I'm empathetic to that, but I treat them for TB or HIV or something like that. Move on, don't care about that. And move on from there. So ENS does allow us to be able to go through that. And do that and dig that next further. So it prompts me to then be able to go in, as I'm in the EHR and go into in context. It also allows me when a patient who comes in is saying, oh yes, well, I'm on vacation and I was down in Clearwater and I had an issue. I didn't have my meds with me, so I went to the hospital. What hospital should you go to? The big white one on the water.
Mhm.
If you've ever been down that area, there's about 4 big white ones on the water down there. Turns out they had actually gone to Tampa General, because that's where they were brought and things like that. So, being able to get that information from our, patient, be able to go out and look, I can search on their name in ENS, or I can go directly to their account within and say, well, let me see if we have any records, clicking on the HIV. So I'm going to show you that. Prompt obviously is that quick roster list that I'm getting. HIE is a more directed where I'm clicking and saying, show me what you got on this patient. And of course, we have tennis over all of this. So if somebody in our county health department is clicking on that HIE button, for whatever reason, our security monitoring is out there and ensuring. So it's actually looking and saying, was it appropriate? We can set up VIPs in there. So if Angelina Jolie happens to move to Leon County, we can see if a whole bunch of people are looking into her program. But don't say that for. Right. So prompt, and I'll make this a little bit bigger so it's a little bit easier to see. This is what our users see when they get prompt. So roses and thorns. Roses, we get all of the great information that we're seeing on this. So this is based on my roster of patients that we have. Here's the thorn. It's not based on the visits I have currently. This is based on all active patients that we have seen. So if I haven't seen somebody in 4 years and they're still in active status in my EHR, I'm going to be seeing them. So that's the thorn part of it, and needing to be able to kind of weed through that data. Sometimes the data is a lot.
Why is the fact that you haven't seen them a thorn?
It can be a thorn because of the fact that we can see that they're here, but then since we haven't seen them in 4 years, now we look at something, if it's actionable, then we're having to track them down only to find out they've been under the care of another CHD for, the last 4 years.
Okay, assuming they've been under the care, I would see it as a red flag.
Assuming
Whoa,
they
whoa,
have
And
whoa.
they're not getting care at all.
Exactly.
Right.
Right, and that's, yeah.
I just wanted to clarify, so the panel that we upload to prompt is, it's basically every patient who's had at least one visit
One
in the
encounter.
past three years.
Oh, so it's
So-
like 3 years old.
Yeah, it's 3 years. And and some of our patients might just come one time because they need a TB test for school or for work. So it's I think that's what the
Yeah.
thorn is that
They're really not a client.
They're really not
Right.
client.
So you don't have the ability to flag and
I
categorize?
think we can refine it.
Yeah, it
going
would seem to
forward.
me that would be a
Yeah.
key
Yeah.
function.
Right, these would be the ones to be of concern.
Yeah, these are
right,
the
and
ones that we
others-
used to be monitoring. These are the ones
That's right.
that were negative for all tests and boom, we shoot them out.
Absolutely.
Right.
I believe technically there is a way we can do that. We're working towards that.
Mhm.
So,
But not currently. So on the notifications page, you can see that you get all the pertinent information, in a single view very quickly. Being able to see who the patient is, age, when they were there, what type of encounter that they had, if they have been discharged and things like that. Then we teach the users how to filter a little bit more, digging into this. So as we look at and click on our patient record, I can actually see by clicking here and getting details regarding their visit. I can do searches based on the same information as well. But it's important for us to be able to see, the diagnosis description, patient complaints, facility names, being able to see if they're discharged or if this is still inpatient. Data that really helps me be able to more acutely look at that and assume, determine if I need to dig further and do I need to do that follow-up care, or are they inpatient and they're still in the hospital? And working with that.
Yeah, I would think this is another example where if you had some automatic triggers in the system, they could do that for you. I mean, that's what we're paying these vendors to make for us.
Yeah.
True, and that's.
We're paying them to make it as, as
Take
less
the thing out.
dependent on the human as
Right.
possible.
Yeah, and a little more think of it, because our users are going through and they can take this data and they can filter it. So they can say, show me the ones that have had a discharge date within a week, that I'm more likely that I'm going to be able to dig further and get discharge summaries on. Or I want to look for a specific. You'll see that we have exclude health department because now all 67 of our health departments are connected. So I can look and see if we have those patients in kind, which we have used dramatically during this time of refugee health. And we have now had county health departments working in concert with one another, utilizing an external vendor to see the refugee population and the numbers that we've had. So you have Orange and Osceola, and Osceola's patients are going to Orange and that. So now they can see that and they can see those visits going across. Or be able to even see what one of their patients was on vacation down in the Hillsborough area and had a hospital encounter at the Big White Hospital and being able to see that. But our users are the ones that are putting this through together. All of the data is not always perfect when it comes through on ENS. You'll see that I have an example here for a PROM, so our OB clinic looking for a premature rupture of membranes. And we don't always have that as a diagnostic detailed summary coming over from our acute care facilities. All of the CHDs will have a diagnosis and an ICD-10 code that you'll see on our records, but you don't always get that. So sometimes you just see that they were in the ER or they were in the hospital, but you don't know exactly what it's for. So you do have to dig a little deeper.
Yeah, it's just a presenting diagnosis typically, and because it's not coded in the
Right.
hospital world at
Exactly
the
right.
end.
Yep.
And discharge, then still it's just a discharge diagnosis, but it's not a final code.
But then we get into the HIE. So we have the data that we saw in prompt, and this was just going to run through a little bit of what we do. And then I'm going to go through this slide for you. So we looked in ENS and we saw that we had some of these things. But what we're looking at oftentimes is patient to patient and dealing with that. So you'll see that when we are in our EHR, our HMS, health management system, we can actually go in and click an HIE button. And our CHDs determine who is able to click that button and they get that permission to do so. And then they can go through and they can actually look and see the documented facilities that they've been to, pull these up, look at this information, utilize the cut and paste. And we're going to see this in great big detail as well.
We're like, it's an eye test. Right?
It's blurry here.
Vision test.
It's a CCD.
Yeah.
Okay, thank you.
Now.
Yeah.
Yeah.
So
So this runs through this script, but I'll show you in real time what this looks like. So I need
see
my
better now,
client record
maybe.
here.
Yeah.
So this will be much bigger, much easier.
So this is the HMS.
And this is HMS. This is our federally certified electronic health record. It's pretty terrific. I've used lots of them. So within this record, I'm seeing this patient, Cheddar 8, Cheddar CZZ test, and I can click the HIE button. And it's going to go out to the HIE and say, I have this patient and I want to know. So it's kind of like that, chauffeur holding up the tag and, whenever he's coming off the plane, are you with me? And it's going to return my list of documents from various facilities that they have been seen at. And then I can discern further and say, this is the one I think it is. I can click on this and then I can bring up that list, that document directly from that.
And then what are you doing with that information?
So what we do with that document, and I'll show you one of the ones that can pop up here. So this is a redacted CCD. It's an actual CCD. So you can see that here is somebody that had gone to, and they were in an HCA healthcare facility, a basic CCD. It is a little bit more dynamic, so I can jump, but just by clicking on these areas when I have that document up in HIE. But I'll be able to see the problem list, updates that have been on there. The nice thing about looking at these is if I want to specifically look for a specific year or a specific date, I could jump to those using the control find and being able to pop that up. A lot of what we've been finding, so here's a nice one. We have an OB patient that was in for bleeding. This is somebody who is a pregnant patient. And we can actually see an ultrasound pelvic, and we're getting these results without having to go into a separate system. I don't need to see the x-ray. I need to see what the radiologist said about the x-ray and, things like
The
that.
report.
When you say, oh, sorry.
Mhm.
When you say our patients, so these are Healthy Start patients? Who
This
are
may be a
these?
Healthy Start patient. This may be, an OB patient that's being seen.
But
at
an
the
OB
county
patient
department.
seen at the CHD,
It
which
could
would be
Mhm.
probably a Medicaid recipient, Healthy Start. Shouldn't be uninsured.
Yeah.
Okay.
So
I'm just trying,
Cause
no, I'm trying to figure out. Because this should all be in the hospital data too.
this is what they're showing.
This is the
Make sure.
hospital data.
Oh, this is your, okay,
What
never.
they're showing us.
Is that now you
their
can see it?
access to e-health
Yes.
exchange.
Okay,
or
I'm
the national
totally good.
exchange.
So
Okay.
what we're looking at on this one is we're actually looking at an HCA healthcare document.
Yeah, okay, I'm with you now.
They're sharing with us, they already are getting CCDs from hospitals.
Excellent.
So we're already
Which is
seeing,
awesome.
And the robustness.
and the
of the data.
robustness of the
Yep.
quality of the
Yep.
data.
So if it's a Medicaid patient, it should automatically be in the ENS, so you should be getting that right away. And,
Not just Medicaid. It's not limited to Medicaid.
it's not limited, but it's required.
It's whatever patient they see.
It's
And it's coming out of the hospital. I mean, it's patients coming out of the hospital.
It's not required it's required that the hospitals share
ENS.
their data, ENS data, and it's actually only required if you want to participate in the low income pool.
When
We
you
have,
get lip dollars.
right.
And, and to me, that's everybody, so I'm so.
Right.
To me, that's.
So
everybody.
it's not I just want to be clear that it is not limited to Medicaid. It has nothing to do with Medicaid, the data sharing. It's all patients.
Good,
Correct.
good.
And they're just showing us that which is amazing, that the county health departments now.
Yeah.
have Everything, not only ENS, because this is not ENS.
Right.
This is
This is
us.
the
This is the-
CCD, they're
Right.
coming from a national health
Got it.
exchange
Right.
process. So
Yeah.
this is amazing. I'm so happy that
So
you guys are
it's
connected.
nice, and on our test patient, and we see this now on our patients, real patients. But what you're seeing up here are all of the visits that this patient has had. So the NCH Healthcare, the Adventist Health System, and CHDs that they've gone to.
That's
Awesome.
amazing.
What we find with our
That's so important.
hospitals is that they do a consolidated or an aggregated CCD that covers the span of 2 years. And that's why we teach our users that when you have that aggregated CCD, start using the features of control find. We had heard at some of the HIE conferences, it's difficult when I get 200 pages of something to refine it a little bit more, to be able to look at it, and cut and paste it. And because, we at the county health departments and the Department of Health don't have to do that, we can actually have individual. So I can click on a document specific to that and bring up that very summary, that very visit. And I can see this is from the Miami-Dade County Health Department. If this was a test patient, so you can see our test on there. But what we publish out there are the allergies, the problems, labs that we've done and things like that. So again, when we do have those patients that, maybe seen and tested in one CHD and they go to another county health department, they're able to see that. And that saves us from running expensive tests, rerunning them when we already have the results and can see those. We are able to, cut and paste or bring this document in as a clinical attachment or cut and paste from it into our progress notes. Same thing with the hospital documents. So before, we used to have to go and say, okay, you went to the big white hospital. I think I found out which one it is. Then you're calling medical records. Hi, this is Peggy. We have a patient in kind that was, seen at your facility, and that's weeks. So, that could be 3 days, 30 days, 3 weeks, and now it's 30 seconds. So a big difference. And again, the level of data that we are now seeing because people are finally participating in this. I said before, we were a little ahead of the curve. So before we were all set up for it, we clicked the HAE button and
That's nothing.
and it was a hard sell for us to get our CHDs to say, sure, we're going to do that. You tell me once, I don't see it, I'm not going to do it again. And what we have experienced in onboarding with care quality and with, Commonwealth through care quality and being able to work with our vendors, and really decide how do we get into this and talking with our CHDs and saying, who are the priority ones that are really most important to you? It's not always who you think it's going to be, to be able to get that. So again, now we have, real-time lab, data, and all of the information that I would get directly from the hospital, now in our hands without us having to ask.
Terrific.
So that's absolutely huge for us. And again, you can see that we can see all the way across, and the more people that can be connected, the better it is for us. And our data has now been out there for a couple of years, so that the hospital themselves, if, however they participate in whatever button they click within their system, can see the data that we have, including the lab tests, including, the counseling, the medications, allergy updates, things like that. So that's a very big and wonderful change. And as a nurse, having worked on this, from the perspective of, just working on the RINs before to what it is now, it's awesome. I get very excited when I go into the meetings because I realize the changes this would have made for the patients that I had I known this information. And again, patients will say, I take the little white pill, it's got a stripe in the middle of it.
Yep.
Don't know what it is,
Peggy, I wanted to interject something. We were talking about the types of services that county health departments provide. And one interesting thing that we learned recently when we visited Baker County is that they actually provide primary care to a Medicare HMO population.
Okay.
They,
The dually eligibles.
yeah, they are like the only provider in that area that will take Medicare HMO patients for that plan. So just to give you, additional perspective of what county health departments are doing on a daily basis.
So examples of this, we had an example when we were down south, in one of our counties, and they had a pregnant client that was lost to care. It was also a pregnant client, it was also one of their TV clients. They had multiple connections trying to get a hold of this. And as we were doing the presentation, they said, can you look this patient up? And yes, you can look that patient up specifically without even having to go into prompt and ENS and just clicking it within their
Counties.
counties. And if you don't see anything, then go to prompt and then see. So it's, kind of a two-way that you can use it. One is going to prompt you to do it. The other, if I don't see it, I at least can see if there was data. And so we were able to find this and had a 4-month history of this patient receiving care outpatient at the hospital. And that was huge for those providers, to be able to do that. We have seen, disease control, whereas, for some reason people go in on the weekends to get tested for gonorrhea, chlamydia, and syphilis and things like that. And then we provide that follow-up care. So again, that again is very easy for us to be able to look at and do.
Next slide, Peggy. So you've already got it up.
Is that good?
We only have a couple slides. We'll wrap this up for us. Some questions. So going operational support. Continue to work with our vendors to look at things that are going on with the national networks. There's TEFCA. Some of you may have heard that. That's the future framework for health information exchange. And our vendor, Chris, is heavily involved, engaged with that effort, and they do that on our behalf. Fire technology, it's a new way to get data instead of the old traditional IHE request respond type things. This is a new capability of doing that, and the national standards are driving people toward that solution. And then the US CD1 standards for what are contained in your CCDs and so on and so forth. So there's a lot of things going on there that we continuously work with our vendors and support them on getting that done. Next slide, please. And then some of our strategies. So looking at the shift plan, there's things there that certainly we want to do to meet some of those objectives and those goals. And there's a few things on the horizon, like recently, I think we heard that the who's that? Not Health Finder, but the other one?
Unitas.
Unitas. Yeah, the Unitas program, DCF, a referral system is going to be made available. And so we're certainly interested in what we can do to connect to that referral service and be able to interact or engage with that from our county health department perspective, and how to do that appropriately. And that's maybe is one way. But there's other things that we can do there. So there's a lot of things we want to do. Operational, behavioral health data is something we're interested in for sure. And I think there've been some discussions about that, ACA, about integrating that data and how to get to it and the value of it. Let's see. Certainly expanding capability of this framework we've built to look at things like Narcan usage and so on and so forth and what that is. That's something we're always looking to do. We're going to add other registries, and we're always committed to expanding our connectivity to more and more connections and creating those community partnerships that we need to do. There are community solutions available that aren't part of the e-health exchange framework. And so we have to look at those as maybe opportunities there too. I'd embrace those and on board within our current system. So anyway, that's pretty much it for us. Any questions? Jill, any comments, final comments or thoughts?
That was great. Thank
do.
you.
It's amazing how far you guys
Yeah.
have come.
Yeah.
Yeah.
Yeah,
Are there any questions online? Does anybody have any?
Corinne?
Well, I'll ask a question, maybe someone, so can you go back a slide? Oh, geez.
Maybe.
Okay. So what is the timeline on your second one there, the Unitas?
Honestly, we're just now understanding that that product's available to us. We've had meetings in our prosperity to, prosperity?
Place to prosper.
Or SDOH, the federal.
All these
Way
meetings.
to
Yeah.
prosperity.
We talked about that. We looked at ENS for opportunities with that. Vendors actually talked to us a little bit about the capabilities there too. So we've explored it. We're not unfamiliar with some potential benefits of how to do that, but I think that is a to be done, and certainly we'll be looking at that pretty soon.
Yeah, it seems like that would be a really advantageous next step
Yes,
for your patients.
yes, absolutely.
No other questions?
Thank you. We'll have these slides in our
You'll
part
have
of our
these slides,
minutes.
yes.
Thank you.
Perfect.
Have all the acronyms.
Yeah.
Oh,
Right.
And a test later.
Acronyms test.
Yeah. Thank you to all of you. Really appreciate. That was a great update.
Yeah, it's exciting.
Yeah, definitely. All right. So how are we doing for time? Okay, we're
We're
pretty
right.
much right on time.
Time, yeah.
All right. Jamie, looks like you're up again here to talk about the modifications for Florida Health Finder for the website. So
Let me.
what's that?
get- For some reason, I am not able, did you unshare?
Oh.
Stop sharing?
You've shown. Okay, so Jenkins.
Okay. Okay, let me.
Did you say there was an updated link? Right earlier, for this meeting? Good too.
And while we're trying to figure that out,
Jamie, do you just want to use my computer?
you know, it's a launch game.
It is here.
Okay, so
Just got here.
so we can do that after he finishes. Okay.
Launch has.
You have to tell us how much we love you. Stand behind.
It's just easier on my head. Just buy your lunch.
Thank you.
Okay, they
Uh,
can see this slide, but they,
Let me unshare if you're sharing, Jamie. There we go. And then let me do the view as.
And that
content.
means you can add it.
Yes, thank you.
Okay. So just some background, I think a lot of folks know we've been updating our transparency website.
okay, they can't
One
see
that-
it. So we're good.
That kind of was not updated, that took the most work was Florida Health Finder, which is our most used and visited website. Just to share some background, we started improvements back in February and we focused on a few key areas. One was, well, before I even get into that, I want to share also, we did not have any marketing funds for these websites before. The way we promoted them or did outreach was essentially doing monthly and weekly webinars in-house. We did have one staff member that was committed to just doing webinars every week. They were putting them on YouTube as well. If anybody called and wanted to walk through, she was available to walk through that. And that kind of died down for a little while with just the shifting of priorities and positions, but we were very happy to get some funding for marketing. It was the first time we were able to kind of go there and reap those benefits. And I'll share some of those metrics that we're seeing already at the end. But it's been so fruitful to the point where we've requested some additional funding for marketing because we see the value in it and we want to make sure that we continue building on the engagement we're getting now. But some of the areas that we focused on were discoverability. A lot of that had to do with the search engine optimization, using keywords and phrases so that people could find us out there. A lot of it we would get some feedback on, I didn't even know this information was out there. How are you promoting this? We were printing brochures, putting them up on different tables as the agency went around and did attend different association meetings or events. Or any opportunity we had to speak about it, we would kind of try to drive traffic to the website. We had a little QR code that folks could scan and go to it, but for the most part, the feedback was just like, I've never heard about this, and you have some good information out here, we'd love to learn more. We also looked at how can we measure traffic better. So it's one thing to get the traffic moving, but then it's another thing is to find out, is this information valuable? Were you able to find what you were looking for? How did you hear about us to begin with? Is there something else here we can help you with? So we've added on a survey on the websites that has, I think, about 8 questions. Before it had only 2 questions, but this one has a few more that we're trying to get some information on, actually measuring the value that was put out. We were interested in knowing if people are actually saving any money when they make these decisions. We're still looking at how we can kind of go down the path of identifying a good way to measure that. But we have all this engagement that we're going to continue to build on. But another area we looked at was improving our reach, and I shared earlier some of the different outlets and platforms that we advertised on. That's been just very helpful for us to even learn a lot. That's definitely not something I think we could have done in-house, but we had a really good vendor. We worked with Strategic Digital Services was the vendor that did our paid marketing campaign. And another area was also improving the mobile experience. So we have a lot of surveyors here at ACA that work and use Florida Health Finder daily. Anytime they do a site visit, anytime they go out in the field, agency staff also receives phone calls in-house. Oftentimes they have to go on the website to look at information specific to a facility. Usually it ends up being the provider profile page. And so the ability to have a good mobile experience was key. It looked really good on the mobile view. You can pull up data. You can zoom in on any smart device now and really pull up some of your reports. I will share they're currently working on fixing things and updating things. So if something gives us a message, just be patient with us as we continue to enhance it and work on it. But this is just a quick walkthrough of the cover page. We have similar look and feel as our healthcare transparency landing page. Here are our buttons to all of our other websites. Now compare and locate. This is for Florida Health Finder specifically. This is essentially how to initiate a launch. It's a search that you may be wanting to initiate. So you can either click on that button to search or search for providers down here.
So
Yes.
you're gonna run us through that? Because that's what
Yeah.
I'm having an
Yeah.
issue
Yeah.
with.
Is there a specific example you want to?
Yeah,
Yeah. What would you like to look at?
search for provider.
Which kind of provider?
I'm looking down at the bottom.
The red button.
No, go to your red button because I'm a consumer. So I want to find a hospital. Now I can't say by name. I can't say
Right.
by city. You're asking me
Right, like,
like,
or, our county or.
Answer by facility. If you hit locate, this will pop up the.
right, that's not a consumer friendly. Before, we used to be able to put in a name or if we thought we had a
That ability
name.
is there. It's not on this menu. You do have to initiate an initial search. What we did was we combined the compare and locate. Those were 2 different tools. We combined them into one. So thereby what it does in the long term, it does reduce a lot of the clicks. But as soon as you launch a search, you do have the capability to reduce and limit your search results by city.
I'm just sharing consumer friendliness. This one is not friendly compared to what it used to be. I mean, it used to be much easier for a user, especially an elderly user. Because now you have to go in and if you try to with the map, okay, now I'm trying to find, I'm not sure what county it is in, but I I'm gonna go up by the state and try and figure it out. So go
I
to,
mean, if that type of search, so you're essentially wanting, like, you're looking for a hospital to start there.
yeah,
Okay.
an individual consumer's
Right.
looking for a hospital, and this
And
is
this
a
is a
landing
good tool.
page now.
Right, this is foreign to them completely. They've never
Right.
been on here.
Right,
We did add a video at the very bottom that does provide some, it's a 3-minute video. It does provide a walkthrough how to pull a report. So it does provide some example on at least initiating your search. We are in the process of adding more videos specifically. So if you're looking for a nursing home for a loved one, we're gonna have a video that's gonna walk you through beginning and end how to do that. But if you're wanting to start for a hospital, the easiest, quickest way, and I fully will acknowledge this is not gonna be known until we put some more information out there. But if you wanted to pull all hospitals, by doing the compare quick links, you'll get an instant report of all the hospitals. And now if you're wanting to limit it by specific city, you can filter down by city.
so again, it's just, this is so different than the original, and it was much easier and user-friendly before. Now I think you've made it more clicks and more complicated, but it looks like that's the path we're on.
I would sit here and tell you, we spent a lot of time on specifically reducing the number of clicks. I think a lot of it is this is new to folks. Folks are used to doing it the old easy way. They bookmark a lot of their pages. So they've cut steps out if you bookmarked already a page that's further down. This right here got me here in one click.
Oh, no, you're not there yet.
Well, I've got results from hospitals there somewhere.
Every single hospital in the state of Florida, now you still gotta click down to a different.
Right, so I mean, if you give me a city, let's pull up a city. If there's a specific one or a county. Would there be like, maybe like a Duval County?
No, I'm just saying, go to Orlando. Just do city Orlando.
So if I do that, select my 7 results, then it does limit my results down to 7. So at least I have 7 starting point hospitals to work with from that,
Right.
from that city.
It used to just be one, I could enter it and I
Now-
got there.
There is a proximity search. So the proximity search will recognize your IP address and pull up results based on proximity.
That's, anyhow, all right. I shared my concern that that's what's been expressed to me as well. And I went out and looked at it and said, oh yeah, you're right.
We will take that back.
It's very confusing.
I do agree that it's not, unless you know and walk through, it is hard to know what to do first.
Jamie, a couple questions. So when you're doing these webinars, do you spend time like saying, hey, look down at the bottom, there are videos, you
We
go
do
through all,
the full overview of the homepage and what sections are where, and then
Okay.
we walk through examples.
is it too late to move that video up to the top? So if you, on that homepage, you have that big blue space up in the top here, your site for easy access, could you
Yeah.
pull the video up to that? Because I don't know that people are gonna
Yeah.
scroll all the way down and say, how to use FHF, what, what
Yeah,
is
that-
that,
That was
right?
the feedback we had early on.
Yeah, and I think we had talked about that at a previous
We wanted to
meeting,
put
so.
that- That way people have that. We do have some FAQs. I think the last time you saw this had 4 still pictures. There was nothing on it.
Okay,
We're
yeah,
gonna
I
have-
think we had noticed that last time. So I was trying to track with what you're saying. So we've got between 85 and 90 employers who are members, of the Florida Alliance for Healthcare Value, and they represent hundreds of thousands of lives, right, that are in Florida. So I definitely want to have a webinar training, whatever it is, for our folks so that they can turn around, and let their plan members, employees, workforce associates know, that this is out
Yeah.
there. So where are you in the process of being able to reschedule those? Because I know we had
Yes.
said,
We did.
you needed a table ed and everything, but I think there's not just Florida Alliance, there are other organizations where we can get this out in a different way than, maybe how you're marketing and educating now, because
Yeah.
these are folks. It's about healthcare. Where do I go for care? What information do I need? So,
No, we absolutely are. We're in the process of scheduling. We were trying to do them sooner with the request that came from the House Healthcare Health Subcommittee. We had it kind of shipped over and tend to their presentation needs and the request. We got that done. That's
and what was that they were?
The Healthcare Subcommittee, they wanted to essentially walk through all. our
They wanted, okay.
So we put focus there. We did put this video out, but we knew, okay, we have some updates that we're still going to be working on. The good thing about this is that through your all sessions that we still need to set up right now, we were thinking probably after the holidays is the best, is we're gonna gather the input from you all.
Yes,
And what you would.
that was the intent,
And
right?
now we have the amendment that's about to get done, which would then give us the ability to make those changes. So. this-
So,
this
so
is not-
staging wise, feedback from us, because
Yeah.
there was going to be us being advisory council, right, to see what that training looked like and feedback, like what Diane had shared. And then scheduling for, once whatever adjustments need to be made, that can be made, have been completed. Then what's the strategy for really getting out there and educating about what's available on,
So-
in the new platform?
We're gonna add a button here to request a webinar.
Okay,
And we're pulling her in and actually to help us do a lot of these videos in-house and to essentially be the person that we had in the past that offered our webinars.
Yeah. So if you have targeted audiences like the organization that I work at, we could also figure out a way to get you the kind of feedback you're looking
If you have a.
for.
Yeah, if you have a public meeting that's coming up or anything, we'll carve out time to throw the.
Yeah, we would schedule something specific to it, but we could do follow-up, and get you the kind of information you need about,
Yeah, we do want the feedback. Now, we do want the feedback. Some of this we've gotten and we are moving it through. We'll go back and look at the applicability rate and some of this stuff, depending on who the user is, everybody wants different things. It's been difficult to please.
Sure, I
everybody.
understand.
But a lot of it has been feedback we've gotten and they're working on it now. Trying to tackle the most critical, but we still have all the phase 2 to go through to really fine tune it and make it better. As of right now, I think we do have something scheduled on the 14th with, I believe it's with our surveying team. They have a monthly meeting. We'll be on that one. And typically we'll walk them through the whole homepage and then walk them through, tell us how you use it.
Mhm.
Because then that better informs us on how it needs to be working.
So I'd just like to make one suggestion. Can you go back to your landing page, please? Show your landing page.
This one, yeah.
Isn't that where you say all of it brings you, everybody to this page? This is the main
I'm
landing.
going to,
No.
this is our landing.
There you go.
Oh, okay.
Well, when I put in floridahealthfinder.gov, that's not what I get. I get the other one that has the blue, go back up.
This one.
And then, go to the, I guess, location, because if I'm looking for a,
Location. So you're talking about actually in Florida Health Finder. So this is Florida Health Finder.
okay, so that find a provider, that
Mhm.
red box down there. If in that, there would be a way, when you open it up, if you could somehow just, I'm thinking of the 70, 80-year-old people, the people who are not as sophisticated and understand what counts, they may say, okay, I know I want to find out where Lee Health is or something. I know a name of a hospital, but I don't know what county it's in. I don't know what city it's in.
This is not.
And so if there was a way, because we used to be able to just put in, it's a hospital in the name or it's a hospital in the city, and it would find it for us. So now there's a lot, it's not intuitive for somebody who doesn't know the site. And it's supposed to be for the general population and general consumer, but I feel like the search type is where we get hung up, and it's, tell me what type of provider you're looking for. That's easy enough. You give them a list and they pick it. But search type, it's not
Right.
consumer friendly, the
And
search type.
I'm sure people.
Name would be great. If you could put in there the search type, could you add name?
We can add it and expand this to have that in there. I'm pretty sure we'll double check with Linda if that could be added.
Because that would be really quick for them. They might know the name or city versus the county, because you have a county option. You
Yes,
don't have a
we've heard-
city option.
Some of the feedback we got was that we need to have the ability to search multiple cities at once. So they are working on getting that in. Because you may just have a county that you want to start with.
Well, except that a general consumer is probably not gonna want to search multiple cities at once. So it depends on who's your audience.
Right.
And to me, if the audience is really trying to get consumers to be more informed, then we need to gear this a little more towards a consumer search versus a professional who can figure out how to navigate that.
Right.
Yeah, no, we're using that there, and I think, I do want to say that we do have the search by facility, which is essentially the map by county. It has a drop down, or the proximity search, which would then find the closest to your location. Now, that does also come into play if you have incognito mode on. You're
Right,
explain that
right.
information, it wouldn't show up.
And the general consumer is probably not gonna necessarily understand.
Obviously.
So if you could add to the search type name of provider, and city of location, those additional two search types, then I think that would resolve this whole issue. My whole concern.
We'll take note of that.
Thank you.
I fully hear you. And I know Trish and her team are listening as well to make notes of all these things. I did want to share that if we were looking and having a starting point, once you do get some results, these filters essentially work the way Excel would. If you wanted to look at further defining some of your search results and then it down.
Yeah, if I'm looking at it, it's a little different. I don't, or someone on my team, but I'm most focused on the consumer, the general consumer.
Would you have any potential consumers that could attend a session that, I mean, would anybody?
Yeah, well, that's what I was saying.
An elderly population.
But I would rather look at it first with, us, right? So I think the advisory council members, if they can get on the website and play around it, and then let's get something
let's-
where we can, and then we'll go to that next level.
Well, my
'Cause I-
in-laws live in a retirement community. I'll ask them to get their.
Yeah, well,
friends
I mean,
together.
Yes,
Thank
Jamie,
feedback.
definitely, but I would like for us, the advisory council, to give it
Yeah.
a look and a
that's-
familiarity with it before
A
we
lot of our content we put
turn
out,
it loose.
we wanted to get, it is.
You know,
Yeah.
I didn't realize that.
We would love to have them on there. We know there's a certain level of. We know a lot of these terms, we may be able to navigate this a little bit easier, so any of that feedback would be very.
Yeah,
appreciated.
well, that's what I'm saying. If we want to figure something out, we certainly have a lot of people who can attend, but also get in and
We'll
give
take that as
feedback.
an action item as far as getting the scheduling done with you all.
Okay.
To have your sessions in January.
Okay,
If anything comes up that is absolutely like, hey, this is a must, I have a team of folks that use this for this and is impacting the workflows, let us know about that.
all right. So it's usually the advisory council work through, but then also if any of us are interested in bringing
And-
who we represent,
Right.
our
Have
constituents.
that in at that,
Okay.
at that meeting, we can make it an hour. At the end, we just kind of run through examples. How do you use this?
Mhm.
What would be better? And as we're getting some of the recommendations and as we're sprinting or going through our sprints and implementing that, we're gonna follow up, so have you guys just test it, make sure it's working right.
Okay. Thank you.
Oh, no problem. So this section here is our mega menu. So the old website had the accordion style drop down and it just went on the whole page. We carved this down into categories. So we have like agency information, customer service information, facility resources, just many categories for info. We do have a healthcare education section we're populating now. Some of our external resources we have, so we have some DOH websites that we had linked to in the past that are here still. And this compare quickly, so just like the one-click search results. I will share that if you do try to search for something that's very large, it does take a little while to load. We're working on finding a way to load maybe the first page of results while the search continues in the background. And then somebody can kind of go through and then see other results showing up. Otherwise, you'll kind of be stuck in a loop and you'll get a little error message telling you to limit your search a little bit.
Not if I could search by name. Sorry. Sorry, Jean.
Diane
As we
appreciates all
move
your
on.
hard work.
I know.
But see, it is good feedback because I do, part of y'all's mission is to advise us on the type of information put out there, so. These are a little parts that would go on. I think we might have covered some of this. These are interchangeable. We can update them as needed. We have some multi-IT initiatives here. We can update these as we get further down the road on any new information we put out. Patient safety culture surveys carved out there. Florida RX. Florida Insights, that's a web tool we're currently working on developing with our vendor, Imagine, and once that goes live, we'll have that here. We did look at our most used and pulled dashboards. Now, this is probably more for agency staff, but there may be some facilities that are out there looking at adverse incident reports. But these are essentially pulled up to the surface because in the old website, you kind of had to click around and look to see where they were. These are interchangeable as well. We can load more and take some away if we need to.
Are adverse incident reports publicly available?
Yes, they're out there.
Oh.
And they were out there in the past. I don't have a link to the old website.
I know it, okay. I didn't realize
Yeah.
they were.
I was gonna
This
ask the same question. The adverse incident reports, Is that, are the parties involved named in those liability claims?
They're not supposed to be.
No, so.
Okay.
Let me pull the, let me show you what's out there, because it may be,
We may be talking different things.
here's how it's being pulled currently. But it's not.
Okay.
Hang on a second. Good.
Somebody unmuted that needs to be muted.
Who's Dave, who is still on mute?
Are you unmuted, Jamie?
That might have been me that was interrupting this, Dr. Shapiro.
No, you weren't interrupting.
So from that screen,
I think it's from.
Yes, go ahead, Dr. Spear.
from that screen, can you drill down to any more detail or, so it's just,
If you're asking if facilities are being entered, we provide this information, but it's sorted out.
Okay, perfect.
It's sorted by facility type.
okay, thank you.
And then by diagnosis. I guess.
Thank you.
Dr. Spear, did you mute your line?
Yes, I will.
I think that's.
That was it?
Okay.
Yeah.
Okay. And then the how to use Florida Finder was the next section. We did put a video up. I don't think this one covered the mobile view. We did create a video on the mobile view for the presentation that was given to the doctor subcommittee. We have FAQs here. But again, this is not by any means final. You know, we're still tweaking and working on it. We are finding little bugs and glitches. There is a lot of data that needs to migrate over. If you were to look at the architecture of all the data that's moving, it's like a spider web. It just doesn't stop. But we're looking at ways to really make it more efficient while also not using a lot of space on the servers so that it doesn't slow things up. I've been able to pull this up on my phone very quickly, very easily, unless I'm trying to pull all records. That just seems to be the only limiting thing, but we are looking at a way to address that currently.
Oh yeah, do we have an app yet?
It's not an app, it's just a web version on your phone. So it's a mobile view.
Okay.
You know, we had looked at an app, we know they're costly. There are some concerns there with when you have an app out there, depending on the platforms you're on, whether it's iOS or Android. If they make changes to their system, you may have to make sure you have patches. There's glitches, there's
Makes sense.
A lot.
costs. Yeah, it's just a lot.
Yeah.
And you want to make sure you have the use out of the app as well to make it worth it as well. But this way, whatever changes we make to the website, essentially, if you make the mobile version at the same time.
Sounds good.
I was going to share some metrics also on our website hits. So with Florida Finder, looking back at our last 2 years, we were at approximately 1.6 million in visitors per year. We don't have our 2023 total just yet, but this was prior to having a paid marketing campaign. We did look at the most active cities because we also wanted to make sure that it's not just folks outside of here. And I won't lie to you and tell you we're not combing through our monthly reports and making sure that we're cleaning out any of that data because there's a lot of bots being used. I think at one point we saw Finland had thousands and thousands of hits coming up. Essentially, you know, not to get too technical, but when you do a search, I think it searches and picks a server around the world and uses it, whichever one I guess might be free. We saw a lot of that, so we had to filter that out. But our top 10 cities that are using Florida Finder currently, Tallahassee #1, probably a lot of agency staff are using it. These are unique visitors, so over 19,000 unique visitors. Next was Miami at nearly 9,000 unique visitors. Then Lake Mary at just over 5,000. Tampa at 4,500. Orlando at 4,400. Fort Lauderdale at 3,600. Jacksonville 3,500. Hollywood 2,600. Gainesville 1,900. And West Palm Beach 1,200.
That Lake Mary is very
Yes, that is
interesting.
strange. Yes.
I'm like, wait a minute. I thought, okay, maybe that's all the Orlando market, but then you said Orlando. So
Yeah, Orlando.
I'm confused by Lake Mary.
And as we are enhancing the data analytics piece, we get some very robust reports. Tracking key searches, how long they were on the website, how they got there. So as we get some of that information, because that's all being tracked now as the marketing campaign rolled out, we'll be able to report some of that back to you all. I did want to share for Price Finder, Miami was number 1 on the top 10 visiting cities to that website with 2,300. Number 2 was 1,300, but this is not a city. This is folks coming in with incognito or limited their access, so we can't pinpoint exactly which cities those were, but our number 2 spot was folks coming in that they want to disclose where they're located. Technically number 2 would be Orlando. Then Jacksonville, Tampa, Tallahassee, Fort Lauderdale, Gainesville, St. Pete, and Ocala. And these are folks that are looking to compare estimated prices on some of the services we have on the Price Finder website. For My Florida RX, that website just went live March 1st. We took that over from the AG's office, who was previously managing that with ACA. We've had so far 133,000 total visitors. We're averaging about 544 visitors a day. Some of the other metrics we pulled is that one seems to have about a 25% mobile view and access. So we're going to make sure that also is continue to make sure the mobile experience on their website works. It's not as robust as Florida Health Finder with all the data that it handles. It's essentially a one landing page where you pull results. So we'll pull some more metrics out of that one once we get further down the road. And I did want to share some specific paid campaign. It's not sharing. I do want to share some paid campaign metrics.
Are you going to share additional information or are you just,
Oh, no, this is just one.
Okay.
This was specific to marketing.
okay.
So the marketing campaign rolled out, our flight time was on May 15th and it ended September 30th. Knowing that, also we had some material queued up to go, but wasn't going to go until we're ready to go live. We had on Meta, so the numbers I'm going to share with you are impressions and clicks. Ad impressions are how many times our ads were out there on somebody's webpage or phone. The clicks are when they actually clicked on it. So on Meta, and that includes like Facebook and Instagram, we had over 27 million impressions with 80,000 clicks. On YouTube, we had over almost 26 million impressions with 4,000 clicks. Google Display had 3.5 million impressions with 50,000 clicks. Google Search had 528,000 impressions with 50,000 clicks. Audio spots. So this was, from what I understood, is that folks who have podcasts also can pick and choose and select to run ads. So a lot of them were just swept in that way. So our audio spots, we had over 51 million impressions with 176,000 clicks. Amazon Display had 16.4 million impressions with 21,000 clicks. The landing page that has all of our websites, the traffic in April was 1,265 unique visitors. In May, it was 1,607 unique visitors. In June, when the ads started to run out there, we saw a spike to 132,000 visitors. So that was a huge uptick.
Yeah.
We did drop back down in July to 11,000. But we started trending back up in August to 31,000. In September, when the next round of ads ran, we spiked back up to 163,000. So it kind of shows you kind of the engagement, and obviously when these ads are running out, people are clicking and bookmarking, and maybe we'll go back later. We're tracking how long they're on the website. Right now, I think we're averaging just over a minute that they're on the website. It could be just to find something quick. It could be to just look around. It could be just to bookmark it. But all this adds to the need for us to continue marketing these websites out there. As we build this engagement, we also learned that during this time, being the holidays, we're competing with a lot of retailers, just everybody that's out there. There's a lot of noise in the aspect. So right now, we're not putting out a lot in the marketing paid campaign side of things.
Smart.
But we're hoping to, in the spring, try to do another little run and keep this engagement going. We don't want it to table off and then we get funding for marketing and we end up just getting back to where we are now. So we want to continue building on that, and we're hopeful that our proposals will get approved. I'll stop there and pause for a second. Do you have any questions or comments?
I do. So I'm not a marketing person, so I don't even know if I'm gonna have the right words here, but on my e-signature that I have for my email, if we have an event coming up, we have an image that, you say, click here to register, and then it takes you to the site. could we, and I don't know what the term is for that, but could we have something for, Florida Health Finder and, the Price Finder that we could add to our e-signatures, and we could also share with our members to say, for information on, healthcare transparency, blah, blah,
Yeah,
blah.
we could do that. I think that's very easy. We currently have on the ACA web page a banner essentially
Yeah.
that has the Florida Healthcare Transparency logo, and folks can click on that and go to basically.
So maybe your marketing people could come up with just something,
That's
catchy, easy.
Well,
that's
it's
right,
portable,
right,
that anyone can put it on their web, on their homepage.
Yep, yep.
We have a QR code as well, folks. I don't know how often they're used.
QR codes are used more than.
They are.
anything else
Okay.
now.
I saw restaurants are using them a lot now.
Yeah.
Yeah, so whether that's the QR code though needs some language associated with it. So if they could create something that we could push out, and maybe some of the other agencies with the state, I mean, it might be a good way to get folks there for the first time. Okay.
Take us long. We do, I will share, we did finalize a printed brochure yesterday that we're gonna start printing, and then if you guys have events, we would love to send you guys a packet of 100 or 2 if you guys want to lay them out. That does have a QR code for folks.
Yeah.
It does lay out our 3 websites and what they do.
So QR code would be for your phone, but we also need like for emails and such,
And a
whatever.
lot of these can be embedded with a link. So
Okay.
if it's an image, you can, and as soon as you put your cursor on it, it'll show you that there's a link behind it. If you click on it,
Right.
it'll open a new tab or take you to that.
Mhm.
Yeah, we can do that. We'll take that.
Okay, thank you.
No problem.
Madam Chair.
Yes.
So a couple of questions on the user feedback. You said that we went from 2 questions to 8.
Yes.
When did that happen? And have we analyzed percentage of responses? Because you've done a good job of tracking
Yes.
clicks, but what is the percentage of people that are actually giving us feedback?
We've just started to roll that out. So the survey, while we were in there developing, it was part of a pop-up. We took it down to there were only 2 questions, and the majority of traffic was us. So we got tired of it. We turned on. Rolling it back now, we do have 2 questions and they're there. We just started to get that information in. So it's back on the table. By the next meeting, we'll have some feedback there.
People need bio brief.
I did, that reminds me, I did have some future enhancements and features that I wanted to at least mention. This is where we're looking at kind of improving all around. So we're talking about increasing data availability. We know there are different data sets, different payer data sets out there that we could potentially purchase and add in. Where that can come into play is potentially, My Florida RX specifically, we can add on more pharmacy data out there. It'll give us more pricing on drugs that are being listed currently. We can maybe get more payer data that we can then add to our payer claims database. Some of this may not be able to be done without funding or some potential legislation to pass, but we're looking at those options. We're also checking to see what other states are putting out there to see if we can maybe leverage some of that data ourselves. We're gonna also be doing some animated infographics. A lot of folks don't want to read a 3-page book or brochure on a process. So we're trying to do quick little 1 minute, 1.5 minute of how your journey will go through what you're trying to find. So that's something that we're going to try to go and do soon, especially on the Florida Health Finder website. We're also working on a virtual assistant. So this is essentially supported by artificial intelligence that would get smarter as somebody goes through, but essentially it says, what are you looking for? What information can I help you find? And that's going to help us customize the journey for the user. That's something we're hoping to roll out in this case too.
That's going to be part of my next questions. Because there is no generic search.
Right.
And most people are used to, oh, well, hold on. I don't even want to mess with tabs. I'm just going to put in where I want to go. So you are looking at that
Yes,
stage too.
we're
Okay.
actually already doing that now.
Awesome.
I don't have any time frame of when it'll be completed, but it does have a lot of testing to go through, but we're trying to do that in phase 2.
And then back on the
Somebody came up and
use on the,
You probably want.
yes,
Question.
the user, oh, well,
Oh, go ahead.
okay, back on the user survey. So, just as a user, I find it 8 questions would turn me off. I understand we may need 8 questions to do a comprehensive analysis. I would suggest having the survey being able to be pushed to you no matter how many questions they answer. So if they don't get down to 8,
Yeah.
that's fine. You got to 5, I at least got 5.
We get any results that are put in, kind of like even with SurveyMonkey.
Good.
We do get that.
Because sometimes you have to press I'm finished.
Yeah, this is getting way ahead of it, but something we talked about with our marketing team. What we would like to do eventually is perhaps track somebody's journey over the course of, let's say, a new mom for pregnancy. How is she using the website? What information has she got back? The feedback we got from the marketing team is a lot of that is you need to incentivize them to really participate and give you that returning information. But it'd be a good way if we could identify some folks to track,
Yeah.
or perhaps somebody that's going through being diagnosed with diabetes for the first time, to see how are their hospital visits going, how are they using the website? Are they prescribed some drugs that they happen to look for MyFloridaRx? Have they used the website? Do they find and identify cost savings somewhere? So that's some of the stuff we're gonna look at. The questions would be, probably the best way to get some info to initially follow up with them to see if they would be interested, but we're still trying to figure out the incentivizing piece to see what we could do. But again, that's early on, that's stuff we're looking at. And that's part of the last piece of trying to do enhancements and features down the road is to really try to identify consumers want and need, and make sure we're delivering that very quickly. All in all, I mean, I think there's different ways to measure it. We're not looking at like nothing. Somebody have a question?
Yeah, so just to go back to where you were talking about the search function, were you speaking about using external search engines, Google, Bing, what have you, or is this only within the confines of our site?
This would be only within Florida.
Okay.
So you wouldn't have to actually the website.
Okay, thank you.
And then my last question may or may not be something we can do, but I mean, all of this information is great if you know how to go and get it, but it's also irrelevant if you're an insured person and your plan doesn't accept that particular provider. Are you looking at links over to plans? Even if, I know plans change their subscriber panels a lot, and that's very frustrating to us. But but most of them have consumer hotlines or consumer web links so if you consider doing some direct links over to plans, if not planned companies that have.
Yeah, we'll look at that.
Because it's really not useful unless,
You're right, we do have like a lot of our disclaimer language may say, this is the retail price that somebody coming out of pocket 100% will be paying. Because it does vary depending on, your co-pays, what you've had to pay in the year, where you have, we'll take that back, because I think that's something we can look at.
yeah, I think that would be useful to the consumer.
I think also, Wendy, if I understood your comment, you're even looking for a little more. So if I'm going in to look for a hospital in a certain area, you're wondering, is that provider contracted with United?
Both, yes, that
So
was
it's a
me.
little
Okay,
different.
I see what you're
Yeah.
saying. We don't have that going on right now. We can explore and see what we can do. I think that can come into the further enhancing of things that we wanted to have. With all comprehensive claims data, like for the price finder website. When we get that information, it's not tied specifically to the plan, once I submitted that claim.
No, I know, and that's a huge flaw in the system. I get it. But I'm just more speaking of if I'm a consumer, I have insurance, comparing facilities is irrelevant if all the facilities in that area aren't covered by my plan.
Yeah.
Right, and for my audience, that's super
So
relevant,
yeah.
yes.
And my only caution, as we all know, because we have to put out our own stuff on our own hospital website and we die sometimes, but is providers change. And so I would be concerned about the state trying to keep up with that, but maybe if the health plans had to link back to Florida Health Finder and the health plans
Yes.
indicated. which is
Exactly,
their
right.
providers.
Just
So
some sort of partnership with the
Yeah.
health
Even if-
plans to
yeah.
figure out the best
Yeah,
way. to
even if the
connect the
link
dots.
didn't have the drill down that the patient needed, it would at least
Yeah.
trigger a link. I gotta ask my insurer, can I go to Florida Hospital?
I think linking won't be a problem, but I see what you're saying. Yeah, that's a lot of upkeep. We
Yep.
We went
No,
live and we had
all
dead
too
link.
well.
We had a dead link within like the same day that we.
Yeah.
Well, and there's- there's a lot of nuance from employer to employer if they're self-funded with
Yep.
who they choose to have in network and not. It may not be identical to who they have for fully insured. So it is difficult. So I think maybe we think through you know, what's the best either
Yeah.
information to have there to remind consumers.
Not awarenessing of what the plans are covering, but just reminder.
Keep in
patient,
mind that,
If,
yeah,
for, if you're selecting a facility, I suggest you
Right.
connect with your plan, and then some sort of easy.
but maybe go, you know, to the plans to see if they'll be willing to provide
I
anything.
think a lot of the.
That'd be helpful.
That would be, that's the helpful information we need to be putting out there. I think our team truly believes that we want to make this useful. We know that other states have similar websites. I've heard and seen that some of our websites, like the Price Finder website, not many states have information out like that. We compare two hospitals down the street and then see what they're charging for knee replacement, see what goes into that process. But no, I think we'll work on these learning sessions, anything you guys have, like, continue to have. We'll definitely try to work it if we can, barring any limitations on funding and the scope that we're under, but just to get to the whole transparency focus that we have on, I mean, this is what we're doing. So this is definitely what all hands on deck on our side. And that's what we're going to continue to ask for funding and research. So,
Jamie, you mentioned a printable PDF. Is that something you can share with us too? We can put that on our websites and share with our
Yeah.
members, something
Yeah.
you're saving at event, you know, sharing at events.
I'll give them to the team.
Okay, yeah, anything like that we
And
can
so
push
people are
out.
Sure, and it's, I mean, we have the electronic version of it.
Yeah.
There's links to it.
Yeah.
So, yeah.
Great, thank you. All right, well, we've certainly asked you a lot of questions.
Went way
A
over
lot of,
time.
I wrote a lot of action items. I see that Pam did too and went
Mhm.
over. All right, so our next item is the HIE Coordinating Committee report. We have Craig Dalton here, the chair of that group, to give us the update.
I'm going to condense a 4-hour HIE meeting to a 2-minute report.
Fantastic.
Objective was to elect the officers for the remainder of 2024. Myself was reelected as chairman and Marie Ruddy from the board as vice chair. But the main objective of that meeting was to assist ACA in the procurement of a new vendor for EMS services. And in that process, we really narrowed it down to 3 discussion items. And those 3 discussion items were about data retention, the interstate data exchange, and patient consent. So we had a long conversation, probably an hour each for each one of those topics. With data retention, there was really no opposition to keep the vendor posting the data. Now, there are period requirements that was discussed. So patient panels, which is in existence now for a certain period of time, and it's like also a maximum timeline on the retention of that data, of patient data. So those were the 2 main topics, and also something else that wasn't quite in the notes, but I think there was no co-mingling of data with Florida citizens with if you've got those type of platforms. So just things for ACA to consider as we're running the procurement process in regards to data retention. Interstate data. Oh, go ahead.
I didn't hear you talk about the monetization of the data that there's gonna be storing,
Right.
or the commercialization or whatever you want to call it. That was a very hot topic as well.
Yes, it was. You want to talk a little bit about what?
No, go ahead. You-
That's fine.
I wasn't on the whole meeting. I just remember, and I know that that was something that Ammon was very concerned about.
Yes, so when you store data, that allows you to essentially, what the purpose of storing data is, one is for efficiency, makes things run faster, so you're not querying and pulling. So for the efficiency of the mechanisms of providing ENS, if you're able to store it, it does give you a better ability. So that's my limited tech analysis of why you want to do that, just for that purpose. But when you also store it, then you are also able to do analytics. And when you do analytics, that's when you monetize that data. And the people who are buying that data, with the analytics on it, or, so it allows that vendor to sell data, the analytics of that. And almost everyone was, concerned with that. So there's gonna be some big red flags on what you do. But that is the reason to do it. And that's why vendors would want to do it. So there is a discussion. Thank you, Diane, for pointing that out. But so we recommended that there were some flags put in place on that procurement process that, obviously, if you're a hospital that's providing ENS data, so this is a working example, ENS data, they're storing it, doing analytics, and then selling to a payer
Researcher, payer.
who also then ends up bidding against Advent because now they know, you don't ever want to put our providers of data, hit that against, or have unintended consequences. Where now they don't feel like sharing, when really the purpose of it is better patient safety, better patient care. So it's discussed in the data retention on that.
So so it was discussed, was there any recommendations or resolutions or suggestions for how to prevent the consequences you described?
The intent was for them to give us feedback, the agency feedback, so
Okay.
that when we go through our procurement process, those are things that we are aware of.
Okay, but it might be beneficial to provide some tangible red flags.
Well-
Or the stop gaps.
Right, that's their feedback was, look for, these issues, make sure in your contract or when you're procuring that you ensure in your contract that it's not the data is not
So we would
monetized,
just-
those types of
Absolutely,
things.
straight up prevent it. That's excellent.
Yeah.
Okay.
so-
Because if we don't, then we should relook at the fees they're charging the data sources.
They don't charge the data sources
Only the
fees.
subscribers.
Subscribers are
Well,
charged fees
they charge hospitals.
If you're.
to get the data back.
Right, well, and I thought it was, and also if they were gonna hold it, retain it for longer than the current.
No, there's no
year.
fee for that,
Okay.
just to get it back. Yes. Yeah, but this is a conversation about our procurement and our ongoing procurement, our new
Moving forward.
procurement moving forward.
So I
Yeah.
just have a text that says they can't hear us any longer.
Well, Brian could hear us.
Oh, but we're
You
back.
guys went silent for about 60 seconds there, but you're back on.
Okay.
It's your microphone.
Yeah, it's on. Or Brian wouldn't have been able to hear me.
We're back now, so apparently.
Okay.
And that is a conversation, all of this, and of course, we had the current vendor in the room. And so there's no reflection on how it's currently
Right.
being, it's just,
Moving forward.
it's future state.
Yeah.
And if you're gonna do a future state, what things do we need to be thinking about? Because technology's improved tremendously. Also, attitudes have changed tremendously on sharing of data. Since we started this process 15 years ago. So, so we're trying to match that, but also put it in the guardrails because it protects ACA and the bit, honestly. So the interstate data exchange was the second topic. And there was a lot of expressed interest in that. But there was also a lot of questions. So from the simple workflow of, you got patients, and we're talking about ADTs here, not clinical data, we're talking about ADTs. Coming from New York, patients that have come down, those notes that are not notes, those notifications that go back and so forth. I think most people felt like the regional aspect of that being Georgia and Alabama, where there's a lot of cross state There might be interest in, but again, here is something that I think the client constantly is, well, perhaps, we don't, the patient consent models don't match state to state. So there's possibility that the patients don't want the home New York or name the state to know that there's what's been done down here. And so there are things there there's some bugs. And so is the draw really this what we think it is? Not sure. So the feedback was, I don't know that interstate data exchange should be a requirement in the procurement process or the proposal to do the capability, but there are things that, and again, our effort was to advise, but also thinking of protecting Florida citizens. And moving their data out of here. So it's not just, it's also going the other way and moving citizen data the other way. So that was the discussion, but Diane, yeah.
Well, I just wanted to build on that just a tad because we don't get consent today because they're only accessing it because they're a provider providing them care, and that's allowed under HIPAA. So it would be the same if I'm in a hospital in Georgia. That's allowable for treatment and care purposes. So I'm not sure what, it's more of what's Georgia and Alabama state requirements is the issue more than we allow, because we don't get consent today because it's allowable. We're an opt-out, not an opt-in
Right.
state, if you will.
Well,
Right. Good.
there is, so for the encounter notification service, because we do share mental health data, we don't share substance use disorder data, but we do share mental health data. There is a requirement to have consent. So, but that consent is right now gotten by the data receiver, right? So hospitals can do the opt-out and not get consent. A majority of the data is treatment data that's allowed through HIPAA. It's that mental health piece and then and if we're exchanging with other states, and this is really for encounter data, this is specifically encounter data because of course, we're at a national model for patient records, so data is being shared. Interstate. So in that model, but for the encounter data, because we do share that mental health data, we have not been able to coordinate or work with other states because they would have to share, the providers in that state would have to sign our ENS agreement, Florida ENS agreement today. That's how it works.
Yeah.
Yeah.
Really boil that thing down for you. But I think that the bottom line is do we put those kind of requirements on a vendor when we know that there's bugs? So that was the advice that we gave. The last thing was, and we just touched on a little bit, was patient consent. And the current policy is under it's and I will mess this up, even as I know the answer is not open right now. It's currently consent to receive.
Mhm.
So meaning the hospitals, the providers of the ENS data, they don't have to get consent. They're just flowing it out. And then the subscribers, if you will, have to get the consent from their patients to receive that data, essentially to be on the panel, so that they're, I'm using the technical, so they're sniffing for the ADTs, the alerts that will provide them. So that's the current process. It's been advocated that possibly change that process to where the hospitals are getting the patient consent.
I guess you guys don't want very many to go out.
You know, that's why we talked about it. And so there are reasons to do that. It makes it easier for subscribers. But on the flip side, it's very hard for hospitals.
And likely to get less data.
Yeah.
So when Bruce was presenting on DOH and the ability to share data, it sounded like you're having an easier time of getting out of state information and sharing.
Statement of Services form that they have to sign, the patient has to sign, it authorizes us to put on our ballot. Right, which causes us to be able to see those notifications. It's fairly simple.
Okay,
So they're doing it from the provider side that's caring for the patient, just like we
Yeah.
require today.
yeah.
Yeah.
As opposed
The
to,
patient has to make sure he opts out. They would have to opt
Right.
out.
right. That's different than what,
Okay.
that's the way it should be working today.
Yeah.
And that's as opposed to now the hospitals are gonna have to get a consent. We won't.
Okay.
Since there was still a lot of discussion about patient consent and consent, and this is my personal opinion on that, is having lived through these type of meetings and patient rights, advocates and so forth. It's really, that probably needs to be pushed to legal work. And so that's what the advice was made. So for that particular one, legal work, actually all of the legal work, I think that's the one they were major tasked with. Okay, to deal with this. With that said, that was, I'll let Pam talk about the legal working group, which I did not attend. But that's it from the Hayek. And again, that was 4 hours of, it was very engaging discussion. I mean, I felt like everybody had an opportunity to, chime in and give some good feedback that we can, give to all.
All right, well, thank you. All right, we'll let Pam jump in then.
So can I have a question?
Sure, sorry.
Was the recommendation to allow or put in to consider allowing the vendor to retain the data for 1 year or 2 years? And then also that the vendor would have to be willing to let the provider, whoever is given the data, opt out to not have it retained?
I think that there is a proposal that they're trying to work on now, and which is if the hospital wants to take back. So
Not-
there's
Not allow you to retain the data.
right.
So there's an option to retain it for 1 year or 2 years, I can't remember, and then also provide an ability for the hospital, whoever's providing the data, to say, I don't want my data retained.
I think that's what the recommendation was, correct?
Yes.
But there was a limit to how long they could retain the data.
Right, and well, right, this body with that retention agreement.
If you sign it,
If you sign it, allowed for the flexibility of 1 year or more, right? At a minimum of 1 year, and then you could stop after that. I believe, if you sign that now, the current vendor Point Click Care, I think they only retain it for 2 years anyway. But so, I mean, those are things that we're looking at as we work on that future.
okay.
Yeah, I'd like to I had understood what Diane had understood, so if that changes, yeah, let us know.
Well, yeah, and we'll be doing a procurement. So we'll, yeah, and we'll be limited on what we can discuss during the procurement
Yeah,
process, but
right.
but we're taking into consideration all of the feedback that we get from these bodies and how we should move forward.
Okay, legal work group.
Okay, so the legal work group actually met twice. They met on October the 10th, and then they met again on November the 17th because they could not complete everything in the time allotted on the 10th. So we did get a lot of the same or similar, not all, similar feedback from the legal work group that we did from the Hayek regarding retention of data. There wasn't a lot of resistance to retaining data. However, they were pretty adamant that any vendor that retains data has to be high trust certified. And so that is one of the things that they recommended, is making sure that any vendor that is selected has that high trust certification, because that is a higher level of security. And they didn't have legal concerns, and they were specifically looking at legal, right? So they didn't have any legal concerns about moving to a national model, as long as it could be done securely and with meeting legal requirements and allowing for ensuring that data is exchanged appropriately and appropriate consents are available interstate. They did bring up the issue of who owns the data, and concerns about patient, I don't know, I'm trying to remember the correct terminology, but making sure that patient care isn't harmed or prevented by providers having certain data sets. Like if there was, and so that was an issue, in being able to make sure that if there was an incident at an emergency department where a patient maybe had a really, really bad day, maybe they were really hangry or something and had an outbreak first. If that's noted in the record, making sure that doesn't impact them when they go to another facility.
The retention, because the data is going to be retained.
Right,
now,
right.
They would have that access to the older data.
Yes, yeah.
Aye.
And you can put in a notification if there was an incident, so.
Okay, I'm just trying to figure out.
Mhm. So, that was discussed, and, they also recommended if there was gonna be training material, that the agency ensure that they have the ability to review any kind of training material and security plans, which of course will make sure that we, include that in our requirements. When looking at the consent model, the, legal work group, they're, of course, legally, their input was that to be able to do that interstate exchange with our current patient consent, is that we would have to move to the opt-in model, where the data sources are the ones collecting that consent. And so they basically advised the agency that, depending on the decision you make, legally, that is what they believe that we would have to do. And so it would be, what impact will that have on our, the success of the solution and our ability to move forward. Another option would be to filter mental health data, so that we wouldn't share mental health data. But I'll get into feedback that we got from stakeholders in a little bit, and their opinion on mental health data versus interstate data. So, but that was basically it. The second meeting. The current vendor had provided some changes that would be needed in order to move to their new platform if they are. So we looked at that, and we did get some feedback, and looking at it purely from, are these things that the agency would need to know as we go into our procurement, whether we recontract with a new vendor, or we contract with the old vendor, or contract with another vendor. So any new contract that we had. And so some of it was language that would be cleanup language for us in an ENS contract or ENS agreement. So, which is separate than the agency contract. There's an ENS agreement between the providers and the vendor. So it was looking at that agreement. And so it was really, would be enabling retention of data, enabling interstate data exchange, those types of things within the agreement. We would have to look at those as we go through the procurement process and see what we'd want to keep and what we wouldn't want to keep. in any vendor that is selected, what they would want. And then, one of the couple of things that we did add, or we're looking at adding that we can look at later as we move to a new agreement, was adding in the ability for law enforcement to have access to data during an emergency only through the E+ system and specify that.
How would they define emergency?
Pass legislation.
No, it has to be declared. A state declared emergency.
Thank you. That's
Yes.
the difference. I just
Yes.
want to make sure.
It's a declared emergency.
Okay.
That's when the only time E+ is turned on is when there's a declared emergency.
Okay.
So,
All right.
That's state declared or just?
no, well, a declared emergency. It could be
So like
local and
full-
global. It's a federal declared.
Good. Officially declared emergency.
Yes.
Okay, thank
Government,
you.
government.
Yes.
Got it. Okay, thanks.
Not a tail light out.
No.
No, that is not an emergency.
Right, let's check in.
It may be an emergency for you or the person behind you, but it is not an official government emergency. And I'm trying to make sure there's not anything else that I think I covered, a lot of the conversation was around, at the second meeting was around consent. The ability, one of the, um, things that were pointed out, regarding consent with a model where it's consent to share is, there is greater ability for a vendor, for the patient to be able to go to a vendor to, retract their agreement to, participate. Right now, patients do have to go to, my parents have like 5, 10 providers, right? And they've given consent, they would have to go each one of those and say, hey, I don't want you to share my data anymore. Or receive my data anymore, actually, in our case, in the encounter notification service. So, we do.
So now that you have the feedback from the Hayek and the legal work group, what are the next steps?
We are working on our invitation to negotiate. And we are going to do it as an invitation to negotiate. We're working on that now, working on the language. We are taking into consideration the feedback that we gotten previously when we talked with this group, the Hayek, the legal work group, and also from our stakeholders. So we are actively developing that now. We anticipate that being out in January. And being able to complete that so that when our contract ends in, is it August or September? August, end of August, we should be in a place to be able to do it, whatever transitions we need to do.
So from a policy perspective, how is the agency gonna decide on the consent? Because that's a major
Yeah.
issue and also a
Well,
major.
can the agency decide or does the legislature have to
decide?
decide?
There's the consent model now was developed by stakeholders
Yeah.
providing
Work group.
input,
So I guess.
right?
No, the legislature doesn't have to get.
Right.
So that, I guess that's just my concern of if the agency's leaning towards opt-in versus opt-out,
That's huge.
that's a
Huge
potential
providers.
compromise to the
Yeah.
amount of data that.
Right, the utilization will take a hit, right?
Yeah, and so I just want to make sure also then the providers don't take the hit for that
Right.
drop in ENS data.
Yeah.
So,
We're still in conversations about that piece of it. So, I don't know that an ultimate decision has been made that way. And there are, we'll have to look at the impact. I know that I can give Pam's personal opinion is that, I don't know that the benefit from the feedback we got from stakeholders, to change our model would be worth the bang for the buck, right? So,
No.
but there are others that have to weigh in on that from the agency perspective. So,
Okay, yeah, I just heard loud and clear too, a lot of providers very happy with the ENS data they get today and very concerned about doing
And that
anything that might
process.
compromise that. Now,
Mhm.
even the health department.
yeah, yeah. I know Bruce did bring up, that issue with concerns about less data.
Yeah.
So,
Right. So I guess it's a good segue for us to hear the stakeholder and user feedback then that's gonna be.
Yeah.
Put in, and that's up next, right?
yes.
Okay.
Okay, so, yes, it's a perfect segue.
There you
So somebody
You're welcome.
brilliantly put that on there, and Diane opened it up for me, so, thank you, Diane, I appreciate that. We didn't work on it in advance either, it's awesome. So we did, reach out to our encounter notification, service stakeholders, to get, direct input, both through a survey. We did a survey that was sent out. Plus we reached out, directly to associations, professional associations that got folks together for us, to get input from, we called them listening sessions. So those were very beneficial, very helpful to us. We specifically focused on the areas that Craig mentioned. It was the retention of encounter data, interstate data exchange, and then also the patient consent. And then we also asked for general input about if you could improve the encounter notification service, what would you do? I mean, so the retention of data was really fairly neutral regarding retaining the data. We did get that high trust certification. We heard that a lot. We did hear, at a minimum ISO certification, but preferably high trust certification for the vendor. The retention for data have a time limitation there, and the time frames though were really kind of all over the board. It was really interesting, from 1 year to 6 years. So it was,
Was interesting, and then I heard a couple of practitioners say, it doesn't really matter to me what somebody did 2 years ago if they haven't been seen.
yes.
So really, that's just more data that clouds my space.
Yeah, and talk a little about that
Yeah,
too.
I
Yeah.
was gonna say, it depends on the disease.
Yeah.
Just.
Yeah. Um, they did say that they would want the data to be retained in the lower 48 states. So that was interesting, not necessarily in,
So
Hawaii and Alaska are out for some reason.
And to your point, Canada's out.
And Canada's out too,
So that.
for maintaining data,
For holding it.
holding it, not accessing it, but holding it. Yeah.
That's only if we can do interstate, and that's only if we can get consent.
Yeah. There was again, lots of input about data not being monetized or sold. And then clear definitions about destroying the data after the retention time is met, making sure that there is a process in place that, hey, after this time, this data is deleted, and we want to know what that process is and that it was done, and how can we be sure that that happened. So having a very transparent process for that, for each of those entities that are sharing data.
So what I heard from my guy is definitely a time limit on the retention, but then also the ability to ask them to dispose,
Mhm.
even if it's before the time limit.
Right. Well,
Because if
yeah.
it's time limit, we're only retaining it for 1 year or for 2 years, but I want you to, we're retaining it for 2 years, but I want you to destroy mine after 1 year. I don't want to retain longer than a year. I heard that was
Okay.
something to consider, is to allow, and it might be based on how long the time is.
Right. Well, and if there are multiple times, right? So if we have that flexibility where it's 1 year at a minimum, then other people have it longer, than having a clear um
End date?
Yeah, either having a very clear end date or having a very clear, transparent process for how that's being determined of how long each of these facilities are storing that data and what we're doing to dispose of it after. So yeah, so that's definitely something that we're looking at. Interstate data, there was, some interest in sharing data. It was really interesting that providers that were in the North Florida area were more interested in Alabama and Georgia data. But we did have some folks in the South Florida area that were interested in the, yes, the neighbor data. It was also interesting that depending on how those entities were currently utilizing the data, changed their opinion about if they wanted the data or not. So for those facilities that are doing analytics on the data, they wanted to get those encounter notifications from other states. For those that are specifically using them for encounter-based care, like, you know, they get the encounter and then they go and they reach out to the patient for continuity of care. They really weren't that interested. There's no,
Out of the national.
Right.
Exchange.
right. They were using the CCDs to get the data versus using that for analytics, and they're using it for continuity of care specifically rather than doing analytics on it on their end. So it varied based on how it was being used. There was an overall expressed need for better quality of there would be a preference to have better quality data. In other words, more consistency in the data, like we don't always get discharge diagnosis, we don't always get discharge disposition, those types of things. Fixing that before getting data from other states.
Yeah, that's smart.
Hard.
So,
but it
yeah,
sounds good.
yes, it sounds like it's so easy, but it is, we do realize that, yeah, so. For consent, the general opinion was if I'm not going to be able to get behavioral health, or if I'm going to be limited to that, that is more important to me than interstate data. We did get people that specifically said that the current consent model works for the existing ENS infrastructure, and they really did like the current ENS infrastructure. We actually had one individual that said that Florida's infrastructure was the best of the best. He said for this service, encounter notification service, he did mention a couple of other states that were doing a good job, but he said Florida's model is the best and we need to try and maintain it. We also heard from a lot of hospitals that they have just moved to opt-out models. A lot of them are moving to opt-out models versus opt-in. And we also heard that we needed to work harder on making sure we had alignment with federal changes around, just to make sure that
We're not duplicating.
we're not duplicating efforts. Just general input from folks of interest in a new, if we had a new version of this, they would be interested in getting census reports, readmission risk scores, care team information, who else is working with my patient. We did get a lot of input from practitioners that they are getting a lot of data from a lot of different places, but they are lacking information and lacking a source of truth. Because they'll get ENS data, they'll get data directly from the hospitals because of the Medicare provisions that require it. They get data from health plans, right? They're just getting those same encounter data, and each of them is a little bit different, and they're having to look at them, and then they're having to weed through, okay, which ones, I mean, you think about what Peggy showed us earlier with their ENS alerts, and they're having to weed through those. And so providers are also having to weed through a whole bunch of data directly from the hospitals, directly from health plans, and directly from the ENS service. So
That's because we have competing pieces of legislation.
That's right.
right. Yes.
Trust us hospitals are very painfully aware.
Yes. Yeah, and that goes back to how can we align some of these things? So,
Just don't add more to our plate.
okay. Let's see if we can take some off, right? And so, and then one of some of the big things is just make sure that it's a reasonable cost, a responsible cost. I don't know if that was supposed to be responsible or reasonable cost of services. There's a responsible cost, a reasonable cost for services. In the importance of, we did get feedback that it was important for ACA to govern the program to ensure transparency of costs. That was mainly from the the payers were interested in that. Supporting, definitely to continue to support public health opportunities, the ability to integrate, ENS into electronic health records to make it a little bit easier. We can do that now. It's just, in some cases, it's cost prohibitive. And then the focus on it, and this is where we had the one individual that said that ENS is transactional driven services, really kind of a best in the nation model, and that derivative type models in the market could potentially cause a monopoly, and so we need to be very aware of that. And that was it.
Okay, good stuff.
I think
Questions?
responsible was also an appropriate word because they're telling you, just understand what you're doing. And this is it might be a little more costly, but it's more meaningful versus be less costly and not meaningful.
This is
So
true.
it is responsible costs.
Yeah.
The value of what you're doing.
Any other questions for Pam? Any online? Corinne, can you see anything? It's getting loud in the other rooms, though.
Yeah.
Having a party.
I know, what kind of meeting is that?
Hey,
There's one question as to, for obtaining CCDs, a point customers brought up as being important.
We're not doing CCDs.
Well, there is a service, Archer, that allows for you to, right now, that allows for you to, the system to take when you get a notification, it will ping the eHealth Exchange. If there is a like discharge summary or whatever associated with it, then they can get that with their,
Participate in that system.
right,
Yeah. okay.
right.
That's why I.
So it's an additional, yeah, it's an add-on service. That is a good point there. That was something that there was some interest in. Hey, how can we get discharge summaries with our encounter notifications from those individual practitioners? That would be beneficial.
anybody else online have any questions? Not at this time. Okay, well, thank you. Thank you, Pam. All right, so next item up is to talk about our meeting dates for next year. So we don't have a lot of time before, these are proposed dates, so this is an action item. We don't have a lot of time to get ready for it, but we have talked about having a retreat for a while. And it would be an all-day discussion for us to really, look at, the key areas of interest and how, what is our role? What's our responsibility as an advisory council? So the other meeting dates are up there and you can see those. And they are the regular, 10 to 2 meeting like this one today. I would like to know if there is anyone who would be interested in working with me and with the ACA staff, not only to develop the agenda for the retreat, but also the approach, how are we going to do this? Are we going to find a facilitator? Are there going to be any prep materials we need to, put together, like historical? I'm just making this up right now, or surveying of the advisory council members. So we haven't done any of that yet. It was a lot of years ago that Diane and I were trying to decide how many years, a long time ago. Lisa Rollins was the bureau chief, and I think she had put a retreat together, and it was also in Tampa, it wasn't up here. There was a facilitator. It was a very, very big deal, but it was at a really critical time. It was really,
doing a lot of different things then.
right.
This was
It
like
was like
Breaking back.
2004, 5, right?
this
A
was-
lot happening, right? So that's the last time though that
Oh, I see.
we had a retreat. I don't think we need that scale of thing. And there were multi-stakeholders. I think we're just talking about the advisory council. 'Cause I think if we went back and tried to look at what was done back then, that was a big event.
So it was a very big event. I have a couple of comments that I haven't gotten to that part yet. First off, March 20th, is spring break for Orange County.
Hmm.
So I mean, some of those dates, when you're talking about spring break time, makes it a little challenging. Secondly, I think it might be helpful to have a little bit more time after session ends to understand and have a chance to
Good point.
go through the
Yep.
legislation that passed that impacts the
Yep,
advisory
yep.
council. So
So
that's my,
when are you
my
thinking
thought.
a good time would be? Now, we have to have quarterly meetings.
Mhm.
So
even
May-
later in March.
maybe if we did a regular meeting in March and flipped a retreat to the next time?
Well,
When does session end? When,
Like the 9th or
Third-
10th or,
Yeah.
yeah, 30th,
Yeah,
maybe
yeah.
something. Here, I
I
can.
don't know. So what are you
Um,
thinking?
I don't know, I'm just, that's,
No, it's a great point. Very, very, very good
15th,
point.
you're,
Okay.
We
so
think.
is it they?
I think then when
My
you
eighth.
get into the
It is
summer,
eight, okay.
it's a little bit challenging. Is there an opportunity to do one in May
May.
versus into after school's out and vacations start?
So maybe do a regular meeting March 20th, even though you're saying that's spring break. I don't, just
I'm sorry, I don't have to
just
be here.
Yeah. Are you going somewhere? Well, we want you there. Regular meeting, but could also run the game plan by everybody on the retreat. I'm thinking out loud.
Mhm.
You just scream if it's
No.
painful, okay?
No.
And it could be the last week of March too. It's not
Okay.
spring break. You guys just need to that's just the one thing we've had this challenge.
Well, and
with.
other districts are other weeks too, so it's
Yeah.
not just, Orange
It's usually the
County.
First couple of weeks
Yeah.
of March is our spring.
Then
break.
you get into perhaps Easter. I don't even know when all that is. So how do you want to handle this? I guess in two parts. Do we want to have a meeting, regular meeting first, our next meeting, and kind of see where everything is, perhaps with, the ITN went out and where you all are, and then move the retreat to later?
I think that's a really good idea to go ahead because we'll have more information about the ITN, where we're at with that after March, because we're putting it out in January, so we'll have a better idea. Well, and I don't know, do you know the length of time, Jamie? Would we know then? Because we might not know anything until like June anyway, right?
But you could at least say, this is what the ITN was. We've had this many
We might-
entities respond or something like that.
Yeah.
Yeah, this is where we're headed. So could we look at the last week of March for a regular meeting?
Well, so the ITN's posted in January. When do you expect to wrap it up?
We're gonna have anywhere like probably a 60 to 90-day response period.
So we won't be wrapped up by March.
No,
No.
No, that's what I'm
By
saying.
June.
Just what the ITN wound up being.
Yeah,
there'll be a Q&A period.
Yeah.
but will you be able to talk with us?
No,
Oh, no.
No, we'll
we
be
just
fine.
generally just touch
Just
on
general
it.
stuff, right?
Okay. But you can, okay.
So, I mean, would it be better to have the retreat later in the year than March? Or you're looking at it because we just need to have a strategic plan? Can we have a full develop a plan without knowing what
No.
we're doing with the vendor?
Nope, we can't.
Yeah, I
No.
wouldn't think so.
So when will a decision be made, do you think?
To me, that date works best. If you put it out to September, then a lot's gonna happen between June and September.
Yeah.
That you're probably gonna want in your plan.
I mean, we threw out there, hey, we may want to have the retreat on one of our regularly scheduled meeting dates.
Like do
But
a
if-
meeting and then break into the retreat,
Right,
right?
but but there's nothing that prohibits you from having a separate meeting on another day. So do it like doing it in July or whatever, as long as it doesn't interfere with the Hayek meeting.
We can do with the hype meeting.
Yeah,
We could do it with a Hayek meeting.
Do a hype.
Do it
meeting and-
combined.
Could do a combined
yeah,
meeting.
that might be a good
We
idea.
should have, yeah, the hired folks in on the strategic
And
planning.
maybe even invite the legal.
And the
folks.
legal, were invite our two committees to participate. So could we have these 4 dates just be our regular meetings?
Mhm.
And then we'll come back with a game plan. Well, let's get a committee or work group together who could help figure out now also the dates
I was gonna say,
and
and are these dates confirmed or are these just?
No,
being
you have to
proposed?
vote on them.
propose.
Okay, because I mean, I already know I have conflicts with the dates now that I'm seeing them, which ones I have conflicts with and which ones I don't, so.
Yeah, they were just following the pattern that we had.
That's why I was asking.
Okay, let me back up. We're gonna back up the track a little bit. How about we poll the advisory council members for dates in March, June, September, and December? So we can set the calendar. Is that something that we need to have advisory council action on? If you've asked everybody what their input is and we've set a date? Don't think so. I know that's an action item here,
Mhm.
but is it permissible to email everybody and say, oh, March 27th was a great date, June 20th was great, or whatever it was? Do you have
Yeah,
to bring it back for a vote or anything?
No.
Okay, so let's do it that way, if you don't mind. Let's check and make sure we have quorum for
Okay.
our meetings. We also, it would be nice if those positions that are vacant could be filled, but we won't hold our breath on that.
So I mean, you can send, if you send those dates out, are you, like I could say, no, I'm not available, out of the country. Then you would know, and I mean,
Mhm.
are you gonna then compare and see how many people say, I'm not available, I'm not
Yes.
available? Okay, perfect. And then you might change the dates.
Right.
So I'll let you know when I'm out of the country, so you know my span of time
Yes.
that I'm not available, so you don't have to keep coming back.
Okay, thank you.
Multiple people.
If you know that you cannot make any of these dates now, would you please email Pam? And then we can decide whether, we've got to just come up with a completely different date. I realize there are people who are not here today. All right, so are we set on that?
Mhm.
Okay, so we do need a few people to help think about a retreat. When,
Excuse me?
where,
Yes.
yes?
Can I just clarify if that's March 20th or I heard the 27th thrown out there? Which date did we finalize?
We didn't.
But we haven't. We're going to survey everybody. Sorry, couldn't hear. It's sounding like those dates probably are not ideal for various reasons. So look for an email from the ACA team. But in the meantime, if you could email Pam with those 4 dates that are up there, March 20th, June 20th, September 19th, and December 12th. If you know you're going to be out of the country or have some big competing thing you can't change, would you please let her know so that we can adjust accordingly?
All right,
That
thank you.
helpful? Okay, thank you. And then we do need a work group or whatever we're going to call it to figure out, what are we going to do at this retreat? What's our goal here? I think we've agreed having our two, committees, the work groups attend is a good idea. We also want to see what plays out with the ITN and with the legislature. So a lot of things to factor in. So if there is anybody who would like to think that through, we might need a couple calls to get our act together, but it sounds like figuring out the date is really important too. So the other stuff falls in line. So anybody interested? If not, you can have whatever Pam and I and the team come up with, right?
And I concur that that's how it should be done. I'm good. Whatever you guys decide.
We would really like some help
I have
though.
I have no problem helping and participating. My challenge is don't try and schedule it around, and if I can
Well, I'm the same
participate.
way, so.
I mean, I know, but you're the chair, so between you and our vice chair, I just want to make sure you guys schedule the meetings, and if you want to send me an invite, I will participate if I
Okay,
can.
thank you.
Because that's my challenge is, if I have a hospital that has a big issue, I don't want you to have to reschedule because I'm not available.
Right.
Okay. And
So
Dr.
Diane
Dr.
is-
Shapiro still on? I know he was gonna be in and out.
Yeah.
Okay, sometime we know. We'll ask him if he would like to participate in that work group. Okay, thank you. All right, I think we are to the public comment time, Pam. Are we good?
We are.
All right, is there any, I don't know, are you gonna unmute people? How are you gonna do this?
They raise their hand
They
maybe?
raise their hand. What's the procedure here? If you, there's no, you're gonna raise your hand? Okay. None online. All right, so we do have a public comment in the room.
I just wanted to introduce myself. My name is Shelley Menino. I'm with Valentura Public Benefit Corporation. It's nice to see those of you again that we've met before. We provide health information, consulting, advisory services across the nation, and we've been doing some really exciting work in Broward County with the Broward Data Collaborative and the Children's Services Council, excuse me, to work on a use case to reduce recidivism from youth that have been Baker acted. And it's going quite well, very innovative model that the Broward Data Collaborative has put together to obtain parental consent to share information for their youth that we're excited will really augment all of the great work that you've already done and help increase utilization and adoption of the HIE services that are in place. So we're here to learn and listen and just see if there's any areas where we can conserve the budget.
All right, thank you. Anybody else? Right, I think we're closing our public comments. So Pam, I know you're writing a bunch of action items down. I wrote a bunch down. You want to go first and I'll
Sure.
see if there's anything I caught?
Okay, the first one I have was providing a list of bills at the next meeting that may be of interest to the council.
I wouldn't wait till the next meeting because I think if there are bills you want us to take a
Email them
look at, can you
afterwards.
email them to us? So bills that would relate to this. I wouldn't wait till
Okay.
March or whenever we're gonna be doing it.
Okay.
If you need a date certain, you could pick like the second or third day of session when all the original bills have to be. If you want to do a lump.
Okay.
Yeah, so if you wouldn't mind emailing
Okay.
the numbers of them and we'll know to watch.
Okay. The second was to
Get a copy of the bill review for.
bill analysis. I was trying to remember
Yeah.
what my acronym was.
Okay.
Speaking of acronyms, yeah, check on council getting bill analyses. Jamie's going to do that for us. Look at
And that you can send to us before, as soon as.
if
it's
if
available?
available, yes,
Right,
if
okay.
we can do that.
Thanks.
Have staff look at Senate Bill 638 language to make sure it's clear what the intent meets the language.
688.
I thought it was 630. 668.
What I have.
668, sorry. Yep.
Yeah.
Yep, sorry.
Look at look at moving the training video on the transparency landing page to the top.
Okay.
Adding for Florida Health Finder, adding to the search type city and name,
Provider name? Yep.
provider name is
Provider
what
name,
that
yeah.
I mean by that.
Yep.
Advisory council members get input from consumers and organizations that they represent on the transparency website.
So I think the action item is schedule the advisory council walkthrough first of Florida Health Finder, right? And then we'll figure out how to get additional input from our constituents, consumers.
Okay.
So, yeah, thanks.
The only reason I'm not changing my action items is because my pen died.
Oh, I was gonna say.
So yeah, so hopefully somebody else is getting that.
I've got them too.
Let me see if I could read this
I've
one.
got, all right,
Look at,
QR code and an
Yes,
image
look at
with
the-
emails, right? And
wait. There was looking at the signature
mhm,
block
QR
click
code
and
an image,
QR code.
right?
And linking information. Contact
Yep.
information
Yep.
On it for comparisons,
Or some instruction that will
Yes.
clarify
maybe we can
exactly.
do the health plans, some sort of partnership where they can share either traffic back to us or us to them.
Or- Or at least a reminder to consumers that they need to check and make sure their
Mhm.
plans
Participate.
participate.
I have.
And then I
also-
had the send the printable PDF.
And then I have two others, and that would be survey the advisory council members for the meeting
Mhm.
for 2024 and schedule a retreat work group meeting. You have to post
Yes.
that and everything, right?
Right, and then I also added one other one, which was make sure that we invite the Hayek and the legal work group to that retreat.
Okay, yep. Did we leave anything out, anybody? Doesn't sound like it.
So you
Okay,
have to publish the work group meeting,
Mhm.
planning meeting, because there's more than one of us
Right.
Right.
involved, so.
right.
On one hand, it's like better for us not to be involved, but on the other hand, I understand why you don't want it to just be you.
Well, theoretically, you guys are gonna have many conversations before we get to the strategic planning meeting. We're all there.
They all have to be noticed, though. They all have to be
Even if
public.
you're just talking with your chair.
We
No.
don't know.
Right, that's what I was saying.
Okay.
So just the planning though, outside of that, if anybody else is participating.
Right.
Yeah, so that was kind of why I was like,
Okay,
okay,
okay.
I just trust y'all.
Yeah,
Because
I trust them too, but she's
that would-
asking for help.
I know that would
can
limit,
see her
severely limit
face.
your ability to.
All right, well, we'll figure it out. Maybe I'll ask Pam to ask you questions.
Can't do that. That's a violation too.
Can't ask you to ask them for input?
But you
Oh.
can ask him questions. and
Yeah.
then she
Yeah,
can
that's what I'm
decide,
saying. Yeah,
Oh, well,
Oh, I
need
can
to ask-
disseminate to everybody and
yeah.
disseminate back, yeah.
yeah, no, you can. I think you can do that. All right, I think we're good. This was a great meeting. Thank you to everybody who participated, whether you're online or in the room, and we had all kinds of interesting sounds and distractions and technical challenges, but we got it to work. So I believe that we could entertain a motion to adjourn.
Motion to adjourn, but after thanking the chair and vice chair for agreeing to step up again. And-
Amen.
Amen. And of course, commend the staff once again. Excellent meeting packet. I love my packet to be really thorough. And I think going through, knowing what my action items are going to be has been very helpful.
Thank you for thanking the staff.
Yes,
I
thank
was
you.
remiss. I appreciate that. I like the way, the direction we've moved with the meeting materials
Yeah.
too and action items. So,
Good.
yeah, appreciate that. All right, so we have a very long motion, but I think it's really just a motion. And Diane's a second. Okay, all in favor, say aye.
All right.
Any opposed? All right, thank you, everybody.
All of your